Welcome everyone. Thank you for joining us for today's webinar. Today we are presenting Strategizing an Efficient Healthcare Delivery System conducted by Integra Ventures. The main objective of conducting this webinar is to let everyone know why we as a healthcare professionals must update ourselves according to the change in scenario, why designing is essential in minimizing infections, why telehealth should not be overlooked, and why we should be open to its vast opportunities in time ahead of us, why quality plays one of the most important roles in healthcare and most importantly in today's scenario. Integra Ventures is a healthcare projects and consulting organization providing turnkey solutions to the diversified healthcare sector. The firm operates from its offices in Guwahati, Kolkata, Delhi, Bengaluru, Yangon, Kathmandu, and Nairobi. We are empaneled by various public sector agencies like NHM, NetFee, MES, NBCC, PWDs, etc. for providing project consultancy services in varied scope in the healthcare sector with an aim of improving the quality of healthcare services delivery in the states. We have a multidisciplinary team of hospital planning and management consultants, healthcare architects, public health consultants, quality consultants, biomedical engineers, healthcare service engineers, financial and legal consultants. Integra Venture have been credited with the successful implementation of 180 plus diverse projects in both public and private healthcare sectors since 2012 in the areas of hospital facility development, hospital quality assurance and accreditation support, hospital management support, manpower training and capacity development, and public health consulting. We have done 60 infrastructure development consultancy projects, 80 quality assurance and accreditation projects, 40 management consulting projects, and we have trained 300 students till now for training and capacity building. So, without any further ado, I would like to begin the webinar by welcoming our first speaker, Dr. Girdhar Gyani. Dr. Girdhar Gyani is widely recognized as founder of healthcare quality in India. During his tenure as Secretary General, Quality Council of India, Dr. Gyani played pivotal role in formulation and operating of National Accreditation Board for hospitals and healthcare providers for the first time in the country. He was principal coordinator in developing of accreditation standard for hospitals and getting it accredited by International Society for Quality in Healthcare. This was followed up with development of standards for blood banks, radiology centers, dental clinics, wellness centers, and Ayush hospitals. Currently, Dr. Gyani is working as Director General, Association of Healthcare Providers, India. The association is registered as not-for-profit NGO under Society Registration Act 1860. HPI represents vast majority of healthcare providers in India. Mission of HPI is to build capacity in Indian health system with focus on patient safety and affordability. Currently, Dr. Gyani is working as Director General, Association of Healthcare Providers, India. The association is registered as not-for-profit under Society Registration Act 1860. HPI represents vast majority of healthcare providers in India. Mission of HPI is to build capacity in Indian health system with focus on patient safety and affordability.
Yeah, this is Dr. Gyani, and I convey my from the Association of Healthcare Providers India and the Integra, which is our partner. Today we are going to talk about skill gap for the healthcare industry in general and pandemic in particular. Let me show you before we go ahead, where are we presently? What is our present status? Now, India, in terms of health access and quality of healthcare services, has recently been rated at 145 out of 190 country in a Lancet study. Earlier, WHO had done similar exercise where India was 112 out of 191 nations on the effectiveness of healthcare services. Obviously, I think these ratings have different criteria, but in a way it shows that we have still a lot to do. We have to cover a lot of ground. Of this rating, why we are so low in both the ratings? The reason is, I will like to look at the 4 A's: what availability, accessibility, affordability, and acceptability, which are the 4 components of the universal health coverage. For a nation, universal health coverage is a dream. Every country will like to reach to this goal, that we are providing universal services to our population. Now let me also qualify here, universal healthcare doesn't mean free healthcare to all. It only means that healthcare is available to the population at the cost which they can afford. So it is linked with affordability, availability, and access. Now, let me see that WHO says that for developing countries, we should have at least 3 points per thousand population. Where are we today? We have roughly 16 lakh, 1.6 million beds, which is coming to 0.3 beds per thousand population. So this is one simple reason of availability, we are poor. Let us look at the other aspect, availability of the resources, that is doctors and nurses. We have 0.65 doctors available for 1,000 population against the 1.0. Same is the case with nurses. We have around 1.5 nurses per 1,000 population against the 2.5. So this is the availability of doctors and nurses. Same is the case even with the allied healthcare professionals. Unfortunately, we do not have here the Healthcare Professional Council, which can set up the uniform yardstick for qualifying the healthcare professional. We do have Healthcare Sector Skill Council with limited coverage as on date. So, if you see in terms of resources, we have to achieve a lot of ground. Coming to the accessibility. Accessibility means that people have to travel a reasonable distance, which can they approach based on the emergency. They can reach out to the healthcare facility, can be a hospital, can be a nursing home, can be a primary health center, can be a community health centers. We had a serious problem. What we find is that the tertiary care hospital are all confined within the 10 and 2 cities. Rural and tier 3 towns do not have any specialist hospital. So people have to travel a long distances. That makes, for example, let me say that Tamil Nadu, for example, they have 200 plus specialist hospital, what we call, with a bed size of 100 and above. 50% of that is confined to only 2 districts, Coimbatore and Chennai. So that means remaining district will always be short of the healthcare services. Over and above, we have not been able to have good compliance of regulation and quality in our country. And finally, India is 129 out of 189 in the Human Development Index. Human Development Index actually consists of 3 main areas. One is the education, second is the healthcare, and third is the, the earning capacity, or what we call average income, per capita income. These factors also once again are showing us in a very poor light. Because of the same reason, we are very low on the healthcare as shown above, and the per capita income also is low. So I think we have to understand that before we talk of building or bridging the skill gap, you must have available, then only you can upgrade their skill. So actually we have to start afresh in terms of making our people skill-based or competence, what we call. Let me now show here, what is the status of the health sector. The private sector dominates with 80% share in the healthcare expenditure in India. Let me say here that if a country wants to achieve universal health coverage, then the government should have enough resources of its own. That means in terms of hospital, their own hospital, government doctors, available at all locations. Then they can, say, okay, we are going to provide healthcare services either free or at the nominal to our entire population. But if you see in India, it is not the case. Today, 70% of outpatient, 6% of all inpatient care is being given by the private sector. That means even if the government wants to deliver universal health coverage, it join hands with the private sector. Otherwise, it is just not possible. Further complication is coming that 85 to 90% of the tertiary care is being delivered by the private sector. So I think this is again a big thing here, that most of the serious ailments will have to be delivered the private sector hospital. In terms of overall spending, if you see here, we have 1.2% of GDP coming from government, roughly 3.5 coming from private sector. That means put together we are below 5% as compared to global average of 0.7%. So you see, again the question here is that we are way below the mark in availability, accessibility, and even the spending in the healthcare. Now, this is all because healthcare was not a priority item in the government, a priority sector in the government. The only way it started was in 2017 when we revised our health, and then in 2018 we came out with a big program, Ayushman Bharat. That actually is the priority which has been given by government for the first time. Look at the manpower situation, because we are talking of the skill, we have to be talking about what is the situation of the manpower. Today we have 500 plus medical colleges with a capacity of passing out 70,000 MBBS graduates, and along with 34,000 postgraduate seats. Question here is, if you can see here that we have 70,000 and half of them only are able to do the post-graduation or the specialization. So over years, we have accumulated huge shortage of these specialists. For example, let us say community health centers, which is a 30-bedded small hospital, rural health, is supposed to have one general physician, one general surgeon, one pediatric doctor, and one gynecologist. All cases, a shortage of 80% in the 5,600 community health centers in India. So virtually you can say that our community health are almost non-functional because they do not have the specialists at these locations. Unstructured allied health, I just mentioned about, not being able to set up the Allied Healthcare Council, the way we have Nursing Council or the Indian Medical Council, which has now been designated National Medical Commission, but nothing of that kind is available for the allied healthcare. Now, this is a very serious drawback, and this is the most important aspect, that if you do not have the allied healthcare workforce like technicians, like GDAs, then we will not be able to manage this kind of healthcare burden. So we really need to upgrade the medical nursing curriculum to strengthen the clinical skills. That is the first thing. Patient safety, medical ethics, soft skill, use of information technology and the medical technology. So these are the requirements which are going to. Now, you see, we just now showed that there is a shortage of 80% of the general surgeons. Now, many times, I think we talk radiology, we talk of neurophysician, we talk of the cancer doctors, oncology doctors, but we do not really talk about the general surgeons. Those actually behind our thought process. I'm just showing the data that the deaths coming from HIV and AIDS is 1.46 million, tuberculosis is 1.2 million, malaria is showing 1.17 million, but lack of surgeries alone kills 16.9 millions. That means 32.6% of the all deaths. 5 billion people have access to safe and affordable anesthesia and surgery all over. India particularly needs 65 million surgeries to be performed every year. We are able to do only 26 million. A simple bellwether procedure, what we call emergency C-section, laparoscopic treatment of open fracture. These are very simple procedure for which we don't need very super specialists. We just need general surgeons. And because of the lack of this skill component in our India, we are able to have, so many people are dying for not making available the surgery. Now, let me bring you another aspect. I'm just trying to compare two states, what we call developed state in the healthcare state, which is not so much developed in the healthcare. Well, why it is so? The reason is very simple in front of us. For example, Karnataka is having 6.6 population, Tamil Nadu 7.7, and Madhya Pradesh, in fact, higher population, 8.5 crores. Now you see how many are MBBS seats available in 8,595, Tamil Nadu 6,850, Madhya Pradesh very poor, only 1,500. Now the state which doesn't have the medical graduate, you now tell us, let us know how can that state be able to provide the healthcare to its population. In fact, all the people from Madhya Pradesh, because there are no seats available, they go across to Tamil Nadu, Karnataka places to do the MBBS, and they never come back. Because after doing MBBS, they will do the postgraduate, and then they will remain in those states. So this is the basic reason. They don't have the medical colleges in the states like Madhya Pradesh, Bihar, Odisha, West Bengal, larger population, but the lesser number of. So the graphical representation, which I already explained to you, that doctor per 1,000 is 0.65 against 1, nurses are 1.3. Similarly, the beds are also 1.3. So this is a simple thing. This is a very crucial point here. You see the percentage of population in the urban area, we have 35% of the population in India is in the urban area. While the availability of the doctor in the urban area is 67%. So 7% doctors are available for 34% of the population, and reverse is for the rural side. So that is the one reason which brings down the quotient in our country. Just let me highlight this, many people are not aware about. The nurses, the backbone of the healthcare system, and their skill is very premium in making sure that we have better clinical. Now see here, I just now mentioned earlier that we need 2.5 nurses per 1,000 population. Kerala has 6.5. That's why you see their health outcomes are number 1 in the country. They in fact compete with some of the developed nations in the world. Karnataka 3.75, Tamil Nadu 3.5, Delhi 3.0. I think these are the one which I can say have very good ratio of the nurses for the population. Now look down, West Bengal 0.75, UP 0.3. Bihar, my God, just dismal. 0.2, 0.2 nurses available for 1,000 population. So I think many people do not see this data. And this is the reason that the health outcomes in Bihar, West Bengal are very poor. We need to immediately upgrade the existing staff somehow and, for the job. Why actually nursing? Actually, we have to actually have more trained nurses in these places. So the nurses' status, whatever the reasons are in front of us, we urgently need to restructure Indian Nursing Council, the way government has done it with the Indian Medical Council. We have to have competency-based outcome curriculum, because most of our hospitals are complaining that nurses passing out from schools and colleges have to be retrained almost for 6 months to 1 year in the hospital before they can be employed or deployed for the jobs on floor. Rationalize the number of institutions. We have unnecessarily large number of institutions in some part of the country where seats are vacant and where not have the. So there has to be a regulation based on the population. We should allow the new nursing institution. We do not have the specialty program in our country. Only one. So this is the main of bringing skill upgradation. For example, you need critical care nurses. There is no program as such which is being run. Really, emergency nurses, operation theater, you need a different kind of nurses. Similarly, everywhere you need specialty in nurses, only the specialty nurses for the management, for the leadership. So this, why it is happening, because what has been realized, compensation pitch for the nurses is pathetic. In many parts of our country, they get less salary than a car driver. Now, this is where some thought has to go on before, if you want to upgrade the skill. Firstly, you must have nurses whose skill you can do. So the basic reason in our country is not so much about upgradation of the skill, but basically to have the right kind of competency nurses. We do not career progression for the nurses. They remain at the same location. There is hardly any nurse leadership program. They do not participate in the clinical management. And I will say, the nurses have to be excellent in the soft skill. Communication and empathy should absolutely be distantly visible in the reality. That is the basic role of the nurses. So this has to be included in our curriculum. Healthcare, allied healthcare manpower, better, because this is the category which has been neglected very badly. Allied healthcare workforce accounts for 53% of the total power of healthcare workers, we call, including doctors and nurses. Such a big percentage has been neglected. India needs 6.1 million allied healthcare workforce, while we are training 0.2 million every year. I don't know how many years now we will take to reach to 6.5 million. Training of allied healthcare workforce is absolutely unstructured. Every state has its own way of doing it. Somewhere universities are doing it, somewhere institutions are doing it, somewhere health council is doing it, and all have them very degree of curriculum and qualifying criteria. This is not a good sign for a sensitive sector like health. In fact, we have time and again realized that if we focus on this sector, allied healthcare, firstly, we have to meet our own demand. In fact, somebody keeps saying that India has capability and capacity because of the large population, qualified. We can train them for the entire world. The global shortage of healthcare workforce, or what we call allied healthcare professionals, we can meet in the sense that we can provide employment to our own youth and also earn good amount of foreign exchange. So this sector needs, and this is for the skill building, this is really a key area. Very simple short-term courses, training programs with the participation of the hospitals and participation of the academic institution, training institution, but unless we have a law which provides, this council kind of umbrella, that under this umbrella or something should come out from the ministry or something should come out from the skill development, all of them have to put together and come out with a straight uniform criteria under which we qualify our healthcare professional for our and in to come, many of them can be given for the other countries. Now, because we are in the COVID time, pandemic time, now the question here is, in pandemics, governments have done good work in the sense, in the short period of time, they have been creating makeshift hospitals, makeshift COVID care centers, makeshift even ICU to the extent I will say. They have tried to procure ventilators, a lot of things done. The question is, can we create the workforce like this? Can you manufacture? You are not able to manufacture the workforce. You really need trained, where actually we are finding problem. In some of the government sectors, we have realized that a lot of ICU beds are in fact lying vacant. While there is a shortage of ICU bed, there is a lying vacant because we do not have the critical care doctors there. We do not have critical care nurses. Do not have trained nurses which can operate ventilators, which can manage the ICU, which can manage the oxygen. So this is the serious lacuna which we have been able to identify thanks to COVID. Now, but something has to be done. So immediately, if something is to be done, the idea which has been floated, I think has been put into action to some extent, are that we can train Ayush doctors because COVID protocols now are known, they are stabilized. Little bit of thing, Ayush doctors can manage the COVID patient. I'm not saying that they will become critical care doctors, but at least they can manage the COVID patient. We have, I'm told, lakhs of foreign trained doctors in India who have still not been qualified through our system, the National Board of Education. In fact, these doctors are available. They can be groomed through very short bridge course, very short, you don't need, because they qualified doctors from countries like Russia, like China, like other countries. Similarly, dentists, number of dentists are available. We can again use this kind of category of people, upgrade their skill, and they will be available to manage the COVID patient. Another area is that final year MBBS students, their internship, instead they can be put into the COVID care under the supervision. And I think this period can be considered as the internship. And in this kind of people who come forward to treat COVID, manage COVID patients, can actually be given preference in the admission to the postgraduate courses. Same thing for the nurses. Final year nurses can be put as interns for management of the COVID patient. And similarly, of course, allied healthcare workers, some people available within the hospital, or some who are not available but have some kind of exposure to the healthcare system, they can be brought into the system through the show. And once the COVID is over, they can be then retrained and regularized into the normal profession. So this is the way you have to manage the gap. And to stop, these are our 10 points. One, we have to increase the medical colleges efficient area. I have shown you the one example of Madhya Pradesh. Same is the case with UP, Bihar, partly Rajasthan, West Bengal, Northeast. You have to increase these medical colleges in the deficient district, not in the district where there are already number of medical colleges. We have to enhance postgraduate seats to create a specialist. Recently, the MDE Government of India has come out with a program to train MBBS doctor through yes diploma in the hospital which have got 100 bed and above. This is an excellent initiative. Similarly, you can more seats in the medical colleges. We can develop fellowship. That means a doctor, if he is working under a specialist for 5 years in a tertiary care hospital, he can win fellowship and be treated as equivalent to the diploma in that particular specialty. Allied healthcare professional bill, which I said in Parliament, it is utmost priority should be given to adopt this bill. We had to rerun the Indian Nursing Council like National Medical. All curriculum in the healthcare must be necessarily competency outcome based. And this is very, very important because we are dealing with the people. We are dealing with the people to reduce morbidity, mortality. We are here to reduce medical errors. So it is very important our grades in medicine, nursing, and similarly in the allied healthcare should be evaluated based on the competency-based outcomes. Patient safety has to be integrated in the MBBS and in the nursing courses, which so far has not been done. Communication, empathy, and soft skills in the curriculum. Now, this is again an area where we keep talking that Indian doctors and nurses lack in the soft skill, they lack in the communication, they lack in the empathy part of it. I think these are the important ingredients of the healthcare system. So this has to be an important area. And if we have to talk of upgrading the skill, I think this is the one area where existing doctors, existing nurses, existing allied healthcare workforce, we must create the modules for training people on communication, empathy, resilience, and in the other soft skills. Accreditation of medical and nursing colleges is the key figure because these doctors are passing out from these colleges. So if these colleges are being accredited by a criteria, so that we that they do not only necessarily come out with the competency-based outcomes, they also come out with the soft skill, they also come out through the safety. So I think the accreditation criteria in these two areas should be designed very meticulously so that you don't have to train them. If they come out from the colleges straightway ready to serve, and that can only happen if you are able to build these these skills through their medical colleges and their nursing colleges. Career progression is again very important, which should be linked to training, retraining of the clinician, nursing staff, and healthcare workforce. This career progression should be definitely linked that, okay, have you done so much of training hours in so many years, and you see their ratings, and based on that, able to upgrade in skill. And finally, follow the global standards in training. Now, this is not only from the point of view that we are looking for placing our youth in the global market, but they are in a way going to help us, because if they are trained as per the global benchmarks, obviously they are good also for our own country. So I think this issue where actually I will say many countries do have bilateral arrangement in other sectors. Why can't we have bilateral arrangement with other countries in the healthcare? So at least we harmonize and we deliver the training to these people, including the doctors, including the nurses. Today, doctors are recognized only in some few countries, not entire world. Why can't we have the global arrangement that our doctors are trained and in their skills? So they are world over. Same thing about nurses, but I am laying more emphasis on the allied healthcare workforce. So I think in I would say that skill is an important component in the healthcare. It is one part of the competence which is designed by education, training, and the attributes. So these three components where training for the skill development is very important because here is a professional subject. It is dealing with the lives of the people. So the skill should be treated at far greater priority in the sector of healthcare. But as I said, before that, we will also have to bridge the gap in making available the number of people. We will be skilling, but otherwise the existing staff have to be upgraded, upskilled, the areas which we have covered in this short talk. Thank you very much.
Thank you, Dr. Gyani, for your expertise. Now we are going to start the question and answer sessions. Over to you, sir.
Thank you, Dr. Gyani. My just feedback is that the role of public health consulting from the perspective of from the corporate sector or the private sector. What is the role of public health? Because the public health pandemic, the context of COVID pickup, the public health pandemic has been going on. So, what is the role of public health to in the current scenario to overcome the issues as well as on the concept of universal health coverage as well? So, what are the key points that public health or the policymakers part can contribute really to overcome the issues and to help the people to overcome the disease? That's my it has feedback as well as if some guidance could be get from the Dr. Girdhar, so would be appreciated.
Thank you, Mr. Adhikari. Dr. Gyani sir, please.
Okay.
Insights.
Yeah, you see, I am very strong proponent of building capacity into the public health. You see, in the pandemic, the first responsibility goes to the public health. The first line of defense should be the public health. I was of the industry task force on COVID, which was advising the government. And we told them that all COVID patients should be treated first by public health, railways, defense, and then only we should go to the private sector. But you know that the public health lacks in one thing: availability of the critical care beds. You see, in the country, we have statistics to show that 85% of tertiary care, that is critical care, is with the private sector. So that is where we came across the serious stumbling. Let me tell you is, in the private sector, they have got more nurses. For 100 bed, a accredited private hospital will have. In the government, we have yardstick of keeping 45 nurses for 100 bed. But in practical, we found hardly 30 nurses are working for a bed. So in the COVID time, a lot of nurses also left. So the public health system, particularly in Delhi and Mumbai, we found huge shortage of critical care beds, ICUs, ventilators, and doctors and nurses into the government. So I think this is a learning now for us that the public sector must build on this aspect. Strengthen the critical care. Make sure you have adequate. You know that government data is that 80% vacancies are there in the community health centers for the specialists. 80%. Gynecologist, pediatric, general surgeon, general physician. All these 4 positions are vacant in the community health centers. I think in government, got very difficult process of selecting recruiting. We keep vacancy in the vacancy. I think these are the learning, and but my view is we must strengthen the public health system if you want to achieve universal health coverage.
Thank you, sir. Thank you. narrating your reply, I would say that the public health sector or the policymakers should focus on the increasing the capacity of the private health sector as well as in public health sector to revise their policies and standards to fulfill the gaps. Thank you. Thank you, Dr.
Thank you.
Thank you.
Now we have Soumya who has raised. Soumya, you can go ahead. You are unmuted. You can ask your query. You can unmute yourself.
Yeah,
Soumya,
yeah.
are you
Good
there?
morning.
Yes, Soumya. Please introduce yourself briefly, and you can
Uh,
make your point. Thank you.
yeah. Good morning to everyone. I'm here, Dr. Soumya. I'm in the field of dentistry all these years. Now I moved to an IT sector for an healthcare. Now, my question is to Gyani that how the dental professional people are up to this now in the COVID times, because there are lack of jobs, there's no job, and they don't have the proper prevention while doing any operative thing in the dental aspects.
Yeah, you see, in the COVID time, dental profession has suffered the most because now we know that this is not coming through the surface. COVID, infection is this coming through the aerosol, and the dental doctors are basically in very close contact with the patient, hardly any distance, hardly not even 6 inches to 8 inches. So that is why I think the most of the patients are not visiting the dental clinics, and that's why I think they are in a very difficult time. I think this is the time during which the dental doctors, like what you are doing, is to build capacity into the other areas like you are doing in IT. Some of you can do administration, some of you can do management, and some of you go into the public health areas. So, in fact, AHPI is launching a program next week from Delhi University and from Chennai University, allowing doctors to do 1 year executive diploma in the management, university diploma. Something like that you can do.
Thank.
Now I would like to introduce our second speaker, Dr. Jyoti Das. Dr. Jyoti Das is the co-founder and managing partner at Integra Ventures. He is a life member of Academy of Hospital Administration and CII National Healthcare Committee, New Delhi. He is a postgraduate in Hospital and Healthcare Management from Administrative Staff College of India, Hyderabad. He has also practiced as a physical therapist before pursuing his post-graduation. By profession, Dr. Jyoti is a healthcare management consultant experienced in handling myriad of projects in the healthcare sector. He has led the multidisciplinary team at Integra Ventures in planning, developing, and commissioning functionally efficient healthcare facilities specialized in the areas of oncology, orthopedics and trauma care, cardiac care, mother and child care, infertility care IVF centers, ophthalmic care hospitals, and multi-specialty facilities.
Thank you, Sangeeta. A very good morning to all the participants of this webinar. Today, we are discussing on some very imperative topics when we are now with this pandemic situation. We believe that we all need to improve our healthcare caregiving. And that process, this webinar is trying to discuss on some pertinent topics. My topic is in how to design healthcare facilities, strategies to improve infection control in hospitals. So I would like to take you to a presentation where we discuss about this topic. Then we will give an overview of the high risk areas in a what are the different high areas and what are the planning principles in developing these high risk areas, and then we will discuss in details about few departments, few high risk departments in the hospitals like operation theaters, the central sterile and supply department, the intensive care units, accident and unit, and isolation rooms. Now, as we know that we are faced with this pandemic situation, and this has, although we have made a lot of advancements in the medical field, but still infectious disease is the leading cause of death worldwide. So SARS has killed almost 200,000 people, and COVID-19 has till now almost killed 1.1 million people across the world. The data was till 1st of October 2020. Now, in this context, hospital faces two types of challenges in terms of infection prevention and control. One is health infection, that is infection from the hospital environment, that can be, as we know, that MRSA, methicillin resistant virus infection, and also hospital has to face challenges in terms of community outbreak of infection like COVID-19 SARS. Now let us take the example of one of US. What is the scenario of US if we, as we consider it as one of the developed developed country superpower? Here, if you see infection control, their Center for Drug Control and Prevention, they say that hospital-acquired infection account for an estimated 1.7 million infections, and out of which around 99,000 people die every year. Just think of this situation in India, Nepal, Bangladesh, Myanmar, and other developing countries where we don't have proper statistics, but I'm sure that the figure will be much more. And what does it do? It actually increases the cost of healthcare. The infection it says that it adds almost $5 billion to the nation's annual healthcare bill, which is humongous. In an effort, what US has done, they have a national healthcare insurance scheme, Medicare. So they have said that the hospitals, they will not be reimbursed or paid for preventable infections, conditions which infectious conditions. So the hospitals need to be better prepared to take care of these infections, and in the queue from the government health insurance scheme, the private insurers have also expressed their intention to not cost for preventable infections. Since hospitals are now responsible for absorbing the added cost, hence they need to take their hospital environment to make it more safe. Now let's this is being opined by one of the hospital authority, where they say that the patients who seek for healthcare service, like one of the patient was looking for hip surgery, and their criteria for choosing a healthcare facility is basically based upon what is the infection rate in the hospital. So the care seekers, they are also very, very concerned about the environment, how strong and control protocols and policies in the hospital, and better all of us, all hospitals across the world need to strategize to improve their infection control policies and protocols. Now let's the WHO's core components of infection prevention and control programs. So if you see, WHO says that if we have infection prevention control strategies in a healthcare facility, there are two kind of things that we need to do. One is the program, the guidelines, the education, training of the staff, retraining of the staff, continuous surveillance, monitoring of how much improvement happening, and then audit and feedback. So that is more related to the process. And similarly, we also need to have a environment, what kind of built-in environment, the antimicrobial material, whether it is used or not, how is the internal air quality, or the equipment and instruments being sterilized. So all these things will also matter equally as the health processes. So WHO says about 5 elements which are multimodal strategies in prevention role in their facilities. One is the hospital has to develop a strong system for infection prevention and control practice, which include developing the infrastructure in that way, the equipment, the supplies and other resources. Second, training of the healthcare workers to abide by the infection control policies and protocols. Then monitoring and feedback, reminder and communications, and finally, a culture of safety has to be developed in the hospitals for a sustainable change. So now let's discuss about the high-risk areas in a hospital. So what are the high-risk areas? Those areas where the patient carry a greater risk of getting infected or infecting others. Now, it has been categorized in 3 ways. You can see where C means the high-risk areas, where the patients might be already infected with some infectious disease, or they might be compromised, where they are vulnerable to be infected very easily because their immunity is lesser. So those areas are like the center, ICU unit, the intensive care unit, post-transplant unit, where the patients are very vulnerable for infection. The second, the B categories of moderate risk, and the A categories of low risk are the general areas. Now, in today's presentation, we are just on the high risk areas. What will be the design strategies of developing high risk areas? Now, let's look at types of infection that one can have, that patients can have in these high risk areas. We are taking the example care unit, burns unit, urological or renal dialysis units, and premature baby or the neonatal ICU. If you see in adult intensive care units, patients are having in general poor resistance, and they need intensive handling of instrumentation, mechanical ventilation, procedures like tracheostomy, catheterization, and intravenous infusions, which they are exposed to infections related to lower respiratory tract, urinary tract, and local wound, infected drift sites, and septicemia. In the burns unit, the patients have lowered local resistance because of the loss of skin and presence of narcotic tissues. So they are also susceptible to various kind of in the renal dialysis unit, where the catheterization is done and patients undergo peritoneal dialysis, the risk of urinary tract infection, peritonitis or hepatitis stands very high if we don't abide by infection prevention and control policies. In the baby units like neonatal ICUs and all, where if the baby is immature, then they have poor immune system developed in them, which will lead to different kind, which may lead to different kind of infections like skin infection, meningitis, and septicemia. Now, let's discuss the planning requirements. What are the planning requirements for prevention and control in these high risk areas? So if we see that the major points in planning these high risk areas are related to the location of these departments, the space allocation, it cannot be very congested, the request has to be given, mandatory facility requirements within a department, there has to be mandatory these or the spaces which are required for infection prevention and control, zoning requirements, internal air quality norms, and then the finish, the antimicrobial finish, etc., that we need to have in these high risk areas. So what are the key points in developing high risk in a hospital? Let's discuss. These are common points. These are common planning points before we discuss the plans in particular. So if you see that while we develop the hospital, then itself we need to various experts who are directing, who will direct in abiding by the infection prevention control norms. So there are various standards that we need to abide by, and that has to be taken care of during the planning stage itself. Now, in terms of the standards, the hospital building needs to meet ISO 9000 and ISO 14000 series in order to renovate buildings and also build new healthcare facilities related to infection control. Then again, we have to segregate different areas with respect to their risk for infection, as we have already seen the three different categories: C, high, moderate, and low risk areas. Similarly, we have to see that there is minimum cross infection through isolation and proper ventilation, which will lead to proper internal air quality, is very much required. So in a hospital, different kind of flows, that is patient flow, staff flow, attendant flow, and material flows, and we need to segregate all those flows effectively to minimize cross infection. We have to also reduce the number of entry and exits to the high risk areas so that we don't expose the patients and other healthcare workers to infections. In the all for risk areas, the departments need to be zoned. What does zoning means is that we zone the departments in protective, clean, and sterile kind of areas. Mostly this is adopted in designing operation theaters and similarly other invasive areas, so that we move towards the PCR area, we reduce the chances of infection by proper zoning principle. The hospital be built in such a way that it is safe not only for the patients but also for the staff and the attendants. Now, while we develop, for example, a 50-bed hospital, we need suppose 2 major operation theaters, and as we grow up to 100 beds, then we will need 3 or 4 operation theaters. The need for the future needs to be incorporated right in the beginning in the planning of the facility. The reason being, we cannot keep on duplicating the high risk areas in different places because the need for maintenance is very high. We need to take in consideration the future developments right in the beginning. And now the world is moving single occupancy rooms which have and there is adequate data to substantiate that there is lesser infection when we single occupancy and less of shared occupancy rooms. But we understand that when we talk about developed and underdeveloped countries, definitely we have to consider sharing facilities, and there we need to take adequate measures to minimize cross-infection. So now let's discuss about some design interventions to reduce infection. So if we speak about like now we know that most of the hospitals they have established proper facility right at their entrance, basically at the entrance of their OPDs, the general entrance and accident and emergency entrance, by a rapid questionnaire to ask them about their history, medical history, and then screen them so that the infection out. Similarly, the finishes of the floors, walls have to be of antimicrobial properties. Those surfaces, all the high risk areas like floors, walls, ceilings, etc., should be seamless. There should not be any crevices. There should not be any joints. There should be as less joints as possible, and all those joints should be properly treated by antimicrobial agents. Then we need to have clean room doors, which can be sensor based, or also which can be and also the material that has to be used for clean rooms has to be of antimicrobial properties. Similarly, ceilings, and so we get a lot of grid ceilings. Grid ceilings are very easy, and if you see that most of the high risk areas need a lot of airing and then electrical requirements and all, and that's why all those things run, those conduit, those ducting, those electrical lines, all these things runs false ceiling, and if the false ceiling are of grid, so that it can be removed and serviced. So but these grid ceilings have to be again of antimicrobial property, and all electrical fittings and water pipes and all cannot dangle out. Those needs to be concealed properly in the critical areas. Hand hygiene, that is one of the major intervention in infection prevention and control, and that's why we need to install adequate hand washing or alcohol hand rub points in the high risk areas. Then internal air quality is of very importance, and we need to develop the internal air quality. The air conditioning of the hospitals are different than general buildings, where the requirement is basically comfort cooling. But when we talk about the hospitals, it is basically we are trying to prevent it, and because of which there are various necessary parameters that we need to fulfill. For example, we need to take care of the filtration level of the air, we need to have the pressure gradient. When we talk about infectious areas, then we need to have negative pressure in relation to the other areas, so that the infection doesn't travel out. It needs to be separate, dedicated exhaust areas in these isolation rooms. Then the filtration has to be done according to the areas. Like if we take the example of operation theaters where we are doing high-end surgeries, we need to have HEPA filters installed there. Or for example, in other places like ICU, there we need to have at least pre-filter or microwave filters. Then apart from filtration, the pressure gradient, we need to also have treated fresh air areas. These are very important to prevent and control infection. Then the hospital has to be designed in such a way that we allow maximum natural light to come in. It has been shown that sunlight kills a lot of microbes, particularly bacteria, and access to natural light also has the positive side effect of boosting the moods of the patients and staff. Now, this is also becoming now very mandatory. This is becoming mandatory in most of the places. The pollution control boards in respective places have made it mandatory, so that the liquid waste which is coming out of the liquid biomedical waste which is coming out of the healthcare facilities needs to be treated before being dispersed into the general drain. So we need to have proper effluent treatment plan where all the outlets are being fed, treated, and then discharged into the general drains. Now, if we take the example of water, as we know that there can be a lot of waterborne disease, and in water requirement is very high, almost 500 to 600 liters per bed per day, and there the water requirement is of different categories. For example, we need general filtered water for all general areas, but in the critical areas we need RO water, we need demineralized water, all these water in the sterilization department for sterilization of the instruments and all. For the dialysis we need RO water. So, and then the pipe fixtures and all what we are using, all those things also needs to be considered to control infection in the hospital. Again, flow of people, equipment and waste in the hospitals, as we have already discussed, that needs to be taken care of. Separation of clean and dirty functions to limit cross contamination is fundamental to infection prevention. Now this is a pictorial representation where we are showing that historically people used to use Tylenol, which are nowadays these are not recommended because these have a lot of joints and there the infection microbes can lodge. So we need to have this surface like the antimicrobial surface in all the critical areas. So use of scientific construction material. We have about the different air quality parameters that we need to take into consideration to have a very safe air quality. Earlier we used to have split AC and window air conditions, but those air conditions are only for comfort cooling in general areas, but they are not suitable for high risk areas where the requirement for treated face air, high ventilation is required, and those facilities are not available in these window air condition or split ACs, which may do greater risk for the patients. So as we see that the disadvantage of window air conditioner, poor control on high noise level, no fresh air, no pressure control, poor filtration, and chances of local fire hazards. So we need to avoid this in hospitals. So these are some guidelines that we need to follow while designing different areas different high risk areas in a hospital, like isolation room, operation theatre, sterile stores which are used in operation theaters and ICUs, then mortuary recovery, dirty utility, and all these areas where if you see there are different parameters like what should be the supply air rate, exhaust rate, the filtration, the pressure gradient that we need to maintain, and all these are into the ASHRAE guidelines. And for details you can mail it to us. So these guidelines we need to follow while designing various departments, various high risk areas. I'll take the example of operation theatre. For example, in operation theatre, what it is being said, on 25 air changes per hour we need to have, out of which around 20% of it needs to be fresh air. So this we need to follow operation theatre. Then we need to have HEPA filters we need to have a positive pressure inside the operation theater in relation to the outside corridor, so that the air infection is always outside and no infection is coming inside, because that will lead to otherwise surgical site infection where the patient is being operated within the operating room. Now, let's take the examples of few high-risk departments like the operation theater complex. We know that in the theater department, we need to provide a sterile field for safe surgery. And the objective is for prevention of all types of infection, only surgical site infection. Validation of operation theater system has to be done as per ISO 14664 standards. Prevention of all occupational hazards, that is for the staff working in the operation theaters. Now, what are the infection control design parameters in the operation theater? To locate the operation theater in such a way that it is not directly accessible to the heavy crowd or the traffic in the hospital. So it needs to be in the higher level, but also since we are now having a lot of daycare surgeries, so we need to have in such that it is accessible from the outpatient departments or the lower floors, and also from the upper inpatient floors. So ideally it is in between floors and the lower or outpatient floors. Then the department has to have control access. We need to have, because as we say that this is a very high risk area, and then it needs to be in adjacent to the surgical ICU and sterilization. Reason being that after surgery the patient needs to be immediately transferred to the surgical ICU if required, if the patient is critical, and ideally it should be adjacent to reduce the risk of infection. And and also the sterilization department, that is after surgeries the instruments which needs to be sterilized immediately transferred to the sterilization department, and after sterilization from the department it can be transferred to the OT without higher distance, without longer distance if it is adjacent. Space allocation for general operation theater, the area requirement is around 350 to 400 square feet, which enough space, adequate space for all the people who are involved in the surgery to be available there with all the equipments and gadgets. Super specialty like cardiac surgery, transplant surgeries, and high-end neurosurgery, joint replacements and all, there we need slightly bigger operation theaters to accommodate all the resources, 500 to 600 square feet, and there has to be adequate width of operation theater corridor. It is around 2.5 meter. The other facility requirements which we need to provide in the operation theaters are proper scrub stations, jointless scrub stations, usually steel. We need to have proper allocated dirty utility rooms or janitor closets, so that the biomedical waste bins are not placed in the open and they are put in the dirty utility rooms, the janitor closets. Then instrument wash area has to be also properly planned in the department. Adequate change rooms and toilets, including the housekeepers, and staff lounge and pantries, so that they don't make the areas dirty, so that we can provide them dedicated space for this. And also we need to have counseling room for the staff for the patient attendance. Now, while designing the operation theater complex, we usually comply to the zoning requirements. We have already spoken about this, that there are three areas: protective zone, clean zone, and sterile zone. So while in the sterile zone, we have the operating rooms, scrub stations, which are adjacent to the operating rooms, so that just after scrubbing, the doctors or the other staff can get inside the operating room. Also, we need to have the sterile store, that is after sterilization, all those sterilized material should be adjacent to the operating room in the sterile zone. Then in the clean zone, we need to have the pre and post operative area where the patients are held before and after the surgery for observation, and then being shifted out. And we have the nursing system which controls the entire operating suite. And in the protective area, basic barrier between the inside area of the operating department, operation complex, and the outside, where the all staff and staff and other people, they need to change before getting inside. So basically, that is the protective area, is the area between the outside and the operating operation complex. So if you see, this is the it's a very broad representation of the traffic flow in a operation theater, where we see this is the operation theater suites, and then from there RT corridor, which was historically it was used. Nowadays, since we have better biomedical waste management protocols, this is also avoided, but the flow is like this, where the patients come in. There is one corridor from the protective zone, then this is the clean, and then is the sterile zone. So usually this is called a TSSU, the Theatre Sterile and Supply Department. But if we have a CSSD in the hospital, then we can avoid you. Usually it was kept in earlier days in smaller places as a TSSU, but in nowadays, for better control, sterilization of instruments from all the departments of the hospital, we usually nowadays have CSSD. So you can see those in the operation theater, the patients, the OT staff, the clean supplies, the use supplies. So if you see one operation theater complex being designed by Integra Ventures, by our organization, here it's a 100-bed facility, and we have planned 3 operation theater rooms. These are the operating rooms, and we have this sterile corridor. There's a sterile store here. We have a scrub station here and there, this place. Then sterile corridor, and this is the door from where the sterile corridor opens. And this area is the clean area, where post-op area, where patients are whole before and after surgery. And from this door, after surgery, the patients are wheeled out the intensive care or towards the patient wards. And the staff, they have a they goes, this is the doctor's lounge and all, change room and all, so they enter from here. Then after changing only they get into the clean room. So this is the protective zone. Similarly, other staff, they get inside from this area. This is the male change area, this is the female change area. After changing, they get inside this clean zone. So it's a very well demarcated unidirectional patients and staff, where they don't get inside the area without properly changing. And while the instruments and the dirty materials has to be clean, so we have a instrument wash area here will be taken, and then we have a CSSD here, which can be and CSSD is placed nearby to the operation theater, so that the CSSDs can be used from the operation theater. We have a lever delivery department here, which can so CSSD can be accessed from this department. We have a surgical ICU upwards, which can be also from this, the CSSD can access from there. So CSSD is placed in a central location, which can be accessed by the operation theater or all the other department. So this is operation theater complex plan, where we have properly demarcated protective, clean and sterile zones. Now we know the advantages of zoning. It minimizes the infection. It minimizes unproductive movement of staff, supplies and patients. It increases the efficacy of the operating team members. It ensures smooth workflow. It reduces hazards in operating rooms, and it ensures proper positioning of equipment. These are the different advantages of zoning. So these the scrub station in operation theatre is of very much important. The scrub station should be wide. It should have proper depth of around 3 feet, so that the water, while we can wash, as we know that while we wash our hands, it has to be there till the elbow. So the scrub stations needs to be enough of enough depth, and these either electronic, there needs to be sensors, or it has to be pedal operated or elbow operated. So these examples of hospitals, operation theatres which we have designed and executed, like this is the scrub, this is a hermetically sealed door, which are and these are the OT corridor. This is the pre and post operative ward in the OT. This is the operating room where we have all the antimicrobial flooring, the wall paneling, and the ceilings, and of high antimicrobial grade. Now, CSSD, Central Sterile Department, second department that we want to discuss, and it is of very much importance. As we know, this is the department which receives, stores, distributes, and controls professional supplies and equipments, both sterile and non-sterile, to and from all departments of the hospital for care and safety. Inadequately sterilized instruments and equipment can cause infection, and that's why CSSD is of very much, and all standards like JCI and ABH says that CSSD needs to abide by strong infection control. So we need to have this nearby to the operation theatre, because the dependency of the operation theatre is maximum on CSSD, though CSSD is also required by other days. It will be also adjacent to the service lift or the dumb waiters if not located in the same floor with the operation theatre. Now the space allocation, standard space allocation for a 100-bed facility is approximately 700 square feet. There are different areas in the CSSD. Here, packaging, license, storage, and dispatch, and proper zoning and proper flow needs to be maintained. The facility requirements, proper wash trolley, the trolley through which the instruments are brought, those trolleys are also needs to be washed and sterilized. So we need to have proper for that. There again, staff change room has to be there. Staff cannot come inside the department from their outside clothes. CSSD manager has to be there, and there needs to be RO, reverse osmosis, and demineralized water for supply to the steam sterilizers, so that we maintain the quality of the instruments. So these are the different zones: soil zone and sterile zone. And this is a pictorial representation where the red shows the dirty utilities coming inside the CSSD. Then that needs to be washed and disinfected. This is usually done in those wash sinks and also the ultrasonic washer. Then this is packaged and then sterilized in this double door usually, and then these are stored and dispatched to different departments. So if you see the base designing CSSD, the flow through the space must be unidirectional from dirty to clean. Pipes, conduit, or ductwork located at work areas should be enclosed, sealed, concealed to prevent dust accumulation. Ceilings should be made of materials that do not particulates. Sterilizers should be located in restricted areas to prevent accidental removal of unsterilized equipment, which will not lead to proper sterilization of the instruments. Hand washing sinks should be readily available so staff can wash after handling items to be processed and before handling processed items. So adequate hand washing facilities needs to be there. Again, environment, internal air quality is of utmost importance in this department as well. ETO is the heat sensitive material, cannot be sterilized in the sterilizers, the autoclave, and that's why we gas sterilization is done, though gas sterilization is nowadays not very popular because of it is environmentally hazardous, but it is being used in still used in many places, and for that we need to have a negative pressure, we need air changes, and then in the other areas also there are air quality design parameters which we need to make for proper infection control requirements. Now next, the department that we are discussing is about the intensive care unit. As we know that intensive care unit houses patients with lower immunity, and that's why it is of utmost is categorized under high risk area. These are separate self-contained section of hospitals for management of patients with life-threatening or potentially life-threatening conditions. So ICUs, as we know, are categorized as with respect to age, with respect to departments, and as we have discussed that these houses patients with poor resistance and then premature babies, immune system, and chances of device related infections are high because a lot of devices are being used on the patients in the ICUs. Catheter, ventilator, infusion pumps, central lines. So what are the different design parameters? Location, I have spoken about surgical ICU, which should be nearby to the operation theater for ease of transfer of patients post-surgery. And also from the operator, from the emergency department, patient may need to be transferred to the ICU. So emergency department and the ICUs usually are placed nearby to the vertical circulation, the lifts, so that they can be easily transferred. And it has to be segregated from high traffic area. Space allocation approximately 100 square feet per bed, and the standard planning norm is that 6 to 12 beds per ICU unit, so that below 6, because the resource requirement in terms of specialized manpower or equipment and all, below 6 beds it is not very financial, and above 12 beds it will be difficult to manage and maintain the infection control norms. So the standard units are of 6 to 12 beds. The facility requirements: adequate hand washing stations, then isolation rooms have to be there in the where there needs to be negative pressure maintained with respect to the other areas where the either the immunocompromised or the infectious patient can be kept. Dirty utility spaces, store the dirty utilities, anti rooms before entering critical areas. So there has to be, usually adopt a double door method of entering these ICUs, and there has to be lesser entry exit points so that we can manage the infection. Emergency exit points definitely needs to be there. The next department that we are discussing is accident and department, and now this is of very much importance because when patients usually nowadays come to the hospital in this pandemic situation, they usually come towards the emergency, that will be screened properly, and patients this is a department where the patient's right to confidentiality and privacy must be protected. Good design will promote efficient workflows and ensure an optimal environment for patients and staff. So location, obviously lower level with dedicated patient screening facility before the triage area. Close proximity to other acute services to minimize delay in patient. The space allocation, we have to have a triage area, we need to have an observation room with observation beds, and also we need to have a procedure area, procedure room. Now, the other facilities which are very decontamination room, if the patient is coming with some biohazardous exposure, so the patient has to be decontaminated. Isolation rooms needs to be there in the in writing of the entrance of the emergency department, and dedicated entrance and waiting space for the of the emergency department. Okay, this is the last high risk department that we are discussing about, is the isolation. This is a lot of importance in this pandemic situation. It is to separate patients who are likely to be infectious to other persons. We need to provide an environment that will allow reduction of concentration of airborne particles through various engineering methods. As we know that most of these communicable diseases are caused through airborne, and that's why we need to take into consideration the environmental requirements, prevent escape airborne particles from such rooms into the corridors. So as I said, that we need to have negative pressure and other areas of the facility using directional airflow to protect patients who are immunocompromised. So location, usually in the emergency department, in the intensive care unit, and also in inpatient wards, inpatient floors. Space allocation, they say that around 2.5%, but that depends upon the specialty mix of the hospital. Upon the specialty mix, we can allocate beds. Approximately around 180 to 200 square feet per room can be allocated for a unit. Facility requirements, provision of anteroom before entering the isolation room. There should be a separate area. It's a kind of a zoning and airlock. Separate arrangements for garbage and infectious waste removal, and should not be mixed with other area waste from wards and departments in form of separate staircase or dumbwaiter and lift. Adequate number of hand wash points are based here. So here I come to the conclusion of this presentation, where I have to give insights into some of the high risk areas and general design principles for infection prevention and control in hospitals. We need to keep in mind that this infection prevention and control designs should ideally be made before a hospital is right at the beginning in the planning stage itself. One, and secondly, in existing facilities, upgrades can be made in the existing material, in existing facilities, so that some renovations can be done to implement these infection prevention control measures. The physical design of a hospital is essential component in its infection control measures to minimize the risk of transmission of any infectious disease. At Integra Ventures, we have had the opportunity to work closely with several facilities to improve their infection control status. So I'll be concluding this presentation with few the kind of work we have done in relation to this. We have created almost 60 projects in the healthcare industry, and which are of different genres. We have done multi-specialty, general facilities, super specialty facilities, single specialties, cardiac, cancer, eye care, mother facilities, orthopedics and trauma care, infertility care facilities, and similarly we have also got experience of working in various educational institutions, including nursing, medical, paramedical, pharmaceutical institutions and all. So now I'll be leaving you with few images, some projects that we have done. This is a cancer hospital. It's being promoted by American Oncology Institute. They have 4 facilities in India and first in Eastern India. This is inaugurated on 15th of September. This is the interior of the facility. We have tried to incorporate all the infection control and prevention measures. This is another facility that we have done and in Meghalaya in India. This is a COVID care hospital promoted by Wipro. We have helped them as the medical planner in converting their IT campus in Pune into a COVID care facility. These are the interiors of the facility. This is a 500-bed hospital in Varanasi, which will be a boon to that place. Again, this is a super specialty hospital with all modern planning standards. This is a trauma care facility that we are doing in Jyoti. The hospital building has been already constructed and all standards have been adhered to. This is another hospital that we are doing. It's a 200-bed facility in Imphal. This is in Uzbekistan. These are 2 facilities. This is one. This is another 2 locations. Then again, another 100-bed, 120-bed facility that we have done. This is an eye care facility. So these are some hospitals and educational institutions. These are nursing, paramedical, pharmaceutical institutions that we have also done. This is a medical college that we have done. It's a 100 admission medical college. So thank you very much for your patience hearing. And I would like to now request any of the friends to please raise any queries, or we will try to address to those in the next 10 minutes. And then if you have further queries or requirements, you can write to us. Our details will be provided. You can mail it to us. Thank you. We also have our WhatsApp number. You can message us. Thank you very much.
Thank you, Dr. Jyoti Das, for your expertise. Now I would like to introduce our next speaker, Dr. Vijay P.V. Dr. Vijay Vivi is the partner and senior consultant at Integra Ventures. He is a life member of Academy of Hospital Administration and Association of Health and Hospital Administrators. He is a postgraduate in hospital management from Administrative Staff College of India, Hyderabad, and bachelor's in dental surgery from JSS Dental College and Hospital, Mysore. By profession, Dr. Vijay is a healthcare management professional with expertise of working in the field of planning, developing, and commissioning functionally efficient healthcare facilities.
Hi, good morning, everybody. Today we would be discussing the topic on importance of telehealth in current pandemic scenario. So more would have now been sensitized about telehealth, telemedicine, teleradiology, tele-ICU and stuff, and that would be in bits and pieces. But let me take you a little bit in detail, a bit of theory and bit of practical experience I'll be sharing on telehealth. So according to New England Journal of Medicine, telehealth can be defined as the delivery of facilities of health and health related, including medical care, provider and patient education, health information service, and self-care via telecommunication and digitalization technology. So it is not just the telemedicine part of it. It can be any part of the patient healthcare delivery. So anything where technology is used and physically they are apart, it would be telehealth in consideration. Just to clarify further, what's the difference between telehealth and telemedicine? So mostly everybody correlated it as same. Theoretically, telehealth and telemedicine are two different terms. In general, telemedicine is used to denote clinical services delivered a registered medical practitioner, while telehealth is a broader term of use of technology for health and health related service, including telemedicine. So as we go further today in the presentation, you will be able to really understand the clear difference between telehealth and telemedicine. So just a small background. So once the pandemic hit the whole world, there was a huge lockdown in most parts of the world or most countries. The complete travel was restricted. Patients were more vulnerable. They were not able to move from place. Hospitals didn't know how to react to the pandemic. They had different sets of challenge to address or to cater to the need of the patient. Then the few hospitals or few healthcare infrastructures were prepared to have a better telemedicine, but none of them were aware that that would be the need of the hour when the pandemic started. So things slowly changed in last 6 to 8 months. Most of the hospitals have adapted for telehealth technology. They are using it in one or other way and trying to better their healthcare delivery system. So, what is the need of telehealth at present in this scenario? Is one to have lesser exposure to a ill person. So today, the healthcare resource people are very you can't produce resources overnight. So there is a challenge in addressing the demand and gap supply. As of now, due to pandemic, there is huge demand, influx of patients who are coming to hospital. You need to actually keep the health of your healthcare workers very safe. So one of the methodology to avoid overexposure is to adopt a telehealth technology. Then the second thing is at present the cost treatment, even a non-COVID patient has gone up because of lot of your personal protective equipment or the new SOPs which have been bought in, so that the infection is not cross spread. So to control the usage of most of your personal procurement, telehealth is a better solution. Minimize impact of patient surge on facilities. Today, since the resources are very scarce, there is scarcity. It's better always to spend more time on telehealth. Most hospitals have senior resources who are above 50 years or above 60 years. In this situation, it is not advisable for them to be in forefront of the healthcare delivery. So using a telehealth technology, they will be able to guide the younger team or do lot of teleconsults, which would bring down the physical load of the hospital. So healthcare systems have to adjust they triage. See, everybody used to rush to a OPD to get a triage done on what's happened to them. They have a fever or they have a cough. Today, mostly using a telehealth technology, you can triage the patient at the home or at their convenient place, and only if need arises, they can be prescribed for either for the diagnostic treatment or hospital visit or hospitalization. So what are the kind of modality have? So several telehealth modalities allow healthcare personnel and patients to connect using technology to deliver health. So there are two types of connect, which is synchronous and which is asynchronous. So basically synchronous is something like a real-time connect. It may be through your audio connect, your video connect, or it may be through any of the technology apps, or it may be through your text and your kind of stuff. But there is a real-time interact between the health seeker and a health provider. In a asynchronous thing, this includes storing required data or of the data, then forwarding it or sharing it with the required healthcare resources. So these are not real time, but say for example your telepathology, your teleradiology, a few parts of your telemedicine on asynchronous method. So then there is also a thing called remote patient monitoring. In this particular thing, you have remotely. There you will not have an active or passive interaction with the patient, but they check on your all your parameters, and in case there is an intervention required, or if there is a change of treatment required, they alert the team at the ground level so that the necessity action can be taken. So what are the benefits and potential uses of telehealth? Teleservice can facilitate public health mitigation strategy during this pandemic by increasing social distancing. So one of the biggest challenges is in a social distancing in a healthcare service, because most of the patients may or may not be infected, but healthcare workers have to treat every patient coming into their infrastructure as a positive case, unless it is ruled out clinically that the patient is negative. Then so using a telehealth technology will help you reduce the exposure. The service can be a safer option for healthcare person and patients by reducing potential infection exposure. They can reduce the strain on the healthcare system by minimizing the surge of the patient demand on the facilities and reduce the use of by healthcare providers. So here, most of the time before post-hospitalization, there used to be a huge follow-up and those appointments lined up. But now most surgeons or most doctors prefer a telehealth mode to do a post-discharge follow-up and stuff. Maintaining continuity of care to extent possible and cover and avoid additional negative consequences from preventive, chronic, or routine care. So, in most of the chronic care, like if you are a diabetic or if you are an hypertensive or diseases, or sometimes on a patient is on a chemotherapy and stuff, they're not really able to travel to the hospital. So they can use a tele health technology and get the basic treatment done there. So remote access to healthcare service may increase participation for those who are medically or socially vulnerable. Today, traveling through any of the public transport, either it may be train. So in this country, train services have not yet started, but your exposure time in a train or a flight of 1.5 hour or a long public bus has chances of you acquiring a cross infection very high. So so it's always better to have a telehealth technology to reduce all this risk, and don't travel unless the need arises. Remote access can also help preserve the patient provider relationship. So in tough times, most of the doctors are worried that they are losing the patient base which they had, because most patients are not able to travel from rural areas or tier 2 or tier 3 towns to the tier 1 town. Today, with a simple 3G or a 4G phone, connect to your doctor, and still the doctor can connect to your patient and have that patient-doctor relation intact. So what telehealth services can be used for? So the major services which can be used for is basically screening of the patient, provide low urgent for a non-COVID-19 conditions, assess primary care providers and specialists, including mental and behavioral health. Today, if you see leading telehealth platforms are surged with lot of psychological and mentally ill or stress related patients. So the guys who require counseling are now absolutely not going physically to any of this infrastructure. They all are very comfortable getting treated through online or through telemedicine. And telemedicine can be or a telehealth can be used provide coaching and support for patient managing chronic health conditions, including weight loss. Yeah, the interesting fact you can observe is most of this fitness company and stuff have really adapted this telehealth technology very well, where in spite of lockdown, where people use their gyms or healthcare centers, they have made it possible with the telehealth technology that they were able to maintain their diet, they were able to maintain their routine physical exercises. There are a lot of institutions which have adapted telehealth for post hospitalization rehab, especially for therapy, your physiotherapy, and other things. So this also helps you. This platform also can help hospitals or doctors to monitor patient vitals and stuff remotely. Say, for example, you are a diabetic patient, you have a schedule to, so you can update or just type in like a WhatsApp kind of thing in any of your app. The data gets updated real time, and doctor will be able to analyze your glucose levels, because today most of the things can be done at home level. Your glucometer, your temperature, your pulse oximeter, your BP apparatus, and most things which can be monitored at your hand, at the patient's hand, and it can be simply keyed in by any person into the app or telehealth platform. Then as we discussed, follow-up of the patients. Then there is delivery, advanced care planning and consultations can be done, provide non-emergent care to residents in long-term care facilities. So because of this pandemic, again, lost a lot of this old age or rehab homes and stuff has been hit badly, because they were not able to really access the healthcare. So telehealth is actually playing a vital role in these institutions to provide a service. And lastly, providing education and training for healthcare practitioners through peer professional medical consultation. So I would like to share, we have recently there was a very high-end case performed for first time in one of the hospital in Chennai. This was a incorporation of an artificial heart outside the body for an old boy. But this particular procedure was done for the first time in the entire Southeast Asia. But the entire team sitting at Chennai were having a telehealth connect with a team of experts from UK, Germany, and few consultants from Russia. And there was a real-time information dissemination, and the procedure was practiced at the hospital on a 3D platform, and it was executed successfully on the patient, where patient has really recovered well, and now he is able to wait peacefully for a heart transplant. So this is a powerful healthcare telehealth technology which can bring. So let's discuss different modalities of telehealth health. So I would majorly focus in this presentation on telemedicine and tele-ICU. Apart from this, you have many other modalities like teleology, telepathology, and mostly it's not very far using robotic surgeries and stuff. Today, telesurgeries be a possible thing in the near future. So teleradiology has been practiced for last 15-20 years. Once the system came into the market, most of the imaging which can be taken at your diagnostic center or hospitals and stuff can be pushed in central cloud, where a set of resourceful radiologists may be in your own hospital chain, or it may be a centralized unit, or maybe a cross-continental or a cross-country consultation. The radiology reporting has been happening. Today, that's a huge market for most of the developing countries, where they have really a good resourceful radiologists, but they are able to still serve people at UK through NHS and people at US through teleradiology platform. And this teleradiology platform, as you are aware, helps you to optimize radiology resources, because giving a radiologist cover in any tier 2, tier 3 hospital 24/7 is a challenge, even though hospitals have potential to pay. The availability of manpower is very much limited in most of these places. So well-trained technician who can take all the images as per the requirement of the set SOP can take the images and upload it onto your PACS platform, where a set of qualified radiologists can actually report the thing. Apart from this, today, like you are aware, every speciality of medicines are becoming too specialized. Today, the kind of reporting a radiologist who is specialized in radiology, or a radiologist specialized in neuro, or a radiologist who is specialized in 3D imaging of a particular abdomen section or stuff is highly specialized. So a particular case from a particular hospital can be actually shared with a highly resourced radiologist at a remote place, teleradiology solution, and still the service can be delivered. And today, in this pandemic situation, everybody would have used across the pathology. Today, the days are gone where you go to a clinic or a lab where they draw the sample, you come back after 2 days to collect a report stuff. Today, even in the remotest place, phlebotomist is able to collect a sample, send those things. I was hearing an interesting case study of Metropolis or Thyrocare, I'm not sure, where they collect samples in a few of the tier 2 cities, African subcontinent, and within 24 to 32 hours, the samples reach the central laboratory, either in India or other, and they are able to report, and the reports means the reports are of world class from a NABH or NABL or CAP accredited laboratories, and these reports can be shared real time with all the patients and the physicians who are in need of it. So coming to telemedicine. So World Health Organization defines telemedicine as the delivery of healthcare service where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for the diagnosis, for the treatment and prevention of disease and injuries, research and evaluation, and continuing education of healthcare workers with the aim of advancing the health of the individual communities. So this definition broadly explains everything of the telemedicine. It can be used in all dimensions for the better of the patient. So On a theoretical aspect, let's quickly understand what are the telemedicine. Be classified into 4 different things according to mode of communication, timing of the information transmitted, the purpose of consultation, the interaction between the individuals involved. So let's look at each of these in detail. So kind of mode, according to mode of communication, like I discussed, it can be a video platform, it can be an audio platform, or it can be a text-based platform. So in video platform today, consultations are happening through any of your apps, or through a WhatsApp, or through a Zoom kind of technology or stuff. Audio, it's a simple technology where you call up the doctor, and the doctor, based on the stuff, will explain you the kind of treatment or primary intervention which is required, and text based. So in all these three, there are different pros and cons. Like video, if you see, it's almost a real-time consultation where physically patient can see the doctor, doctor can see physically. Few of the times using simple technology or the gadgets, the doctors can actually screen the patient very well. There are stethoscopes which can be connected to this digital platform. For ENT, there is an octoscope which doc connect and actually examine a patient. So your BP apparatus or your ECG or a tele ECG can be connected, which can be interpreted real and stuff. That's the advantage of video thing. In audio, the only drawback is doctor cannot see you physically, and he may miss few of the features which can be actually identified otherwise physically. Text based, most of the time text based may not be a direct consultation. It may be for a secondary opinion where all the reports and case sheet and case history is sent, and the doctor gives the second opinion based on the kit and the reports, and it is mostly asynchronous. It's not a real time exchange. So according to timing of information transmitted, like we discussed, it can be real time or asynchronous. And the purpose of the consultation, it may be for a first consultation, it may be for a second opinion, it may be for a follow-up post your discharge. Also, based on requirement, it can be a non-emergency consult, it can be an emergency consult. Today, a lot of young parents would have already in midnight when a baby is crying, they don't know what to do in this pandemic situation. They're not able to take the baby to a nearest doctor or a hospital. So your tele comes into action all this at this time. So this is an emergency consult happening for immediate assistance or a first aid. So based on the or based on the scenario, a doctor can take a decision, give you a prescription to attend to, or based on the symptoms and conditions, doctor can actually alert you to visit an emergency ward in a hospital. Then individuals involved, so the telemedicine can be transmitted into different types. It may be patient to the registered medical practitioner, caregiver to the registered practitioner. So here, caregiver to the registered medical practitioner in most of tier 2, tier 3 town, where most nursing homes have limited access for 24 specialists at the hospital. So a junior doctor or a resident doctor or a nurse in the midnight calls up a senior doctor or the treating consultant, takes telephonic order on what to do when the patient condition is not stable or if they have any issue. So these kind of teleconsults has been happening from the day telephone is in action. But now with the advance in the technology, advance in the platform, you're able to really put this in a better structure where a doctor actually can sometimes patients on real time based on the values of the real time parameters can prescribe medication, and by that 1 hour or 1 hour for a doctor to reach from his house to the hospital so that the patient doesn't suffer. Then registered medical practitioner to registered medical practitioner. Most of the time you would have already come across a junior doctor or a junior consultant consulting a senior consultant through a telephone or a video consultation, or on an asynchronous method to operate case or how to diagnose, or what would be a differential diagnosis. So all this kind of things can be taken care. Then health workers to registered medical practitioner. This is basically a mass training program from different part of the world. Today, a live surgery can be on a Facebook or any of the technology, and most of the junior resources all over the world can actually witness a live surgery or a live process and learn from it. Okay, so I would today come to an interesting topic. This is the tele-ICU technique. Now, in this pandemic condition, you are not really able to access ICU. There is lack of ICU beds in most of the major hospitals. So, how do you bridge the gap? Today, there is a lack of scarcity of intensivist or senior general medicine guy who can handle a critical care patients in most of the tier 2, tier 3 cities. Even in this situation, even tier 1 city or the best hospitals having a scarcity of intensivists. So tele-ICU is the hottest topic which is happening in the situation, where a small bunch of intensivists are able to really manage a very large number of ICU beds, even at the remotest part of the world. So, let's see how this works. So critically ill patients require specialized care. Having an intensivist has been considered the most effective intervention to improve, and the survival of the critically ill patients is very high when a intensivist is monitoring the condition. Specialists in critical care, PG qualifications, either from the internal medicine, general medicine, anesthesia, or pulmonary medicine, or even surgery, who are having MD&B, would fall into this particular category. So let's understand what's the basic problem in this tier 2, tier 3 cities. There is lack of high-skilled critical persons. So in most of the tier 2, tier 3 cities, even though you're able to get one intensivist who can actually take care of in the day shift, but in a night shift or a early morning shift, there is always scarcity of a resource. So this can be bridged through a tele-ICU. Inadequate, inefficient utilization of ICU infrastructure. We ourselves cater to most of the northeastern part of India when it comes to hospital infrastructure service. Most hospitals which we know have ICU setup, but it's not being used or very minimally used because of lack trained human resource. So so this is leading them for inability to deliver quality care. Today, there is lack of confidence of patients in tier 2, tier 3 cities to go to an ICU in their own place because of scarcity of manpower. So there are a lot of medical errors happening because of non-monitoring or telephonic or verbal instructions. So all this can be avoided if effective tele-ICU technology is adapted. So let's see this further. Okay, So what are major problems? There is a supply side issue. You have issue with the doctors and stuff. Patients are willing to pay in most of the small towns for a quality healthcare, but the accessibility, availability is very scarce. So occupancy rate and utilization of these services is always suboptimal. Most of the rural hospitals have ICU beds where the occupancy is only 1 or 2, because most technicians or even the paramedical staff there have very less knowledge, even have even to run a ventilator or a BiPAP or a CPAP kind of thing. So due to inadequate and unstructured expert supervision, so this is all this can be bridged through a tele ICU service. So what critical care specialists lead to improved outcome? So how can they improve the outcome? First thing is improved patient safety, because a real monitoring of all the ICU patients parameter is happening, and even at the first symptom or a first deviational parameter, an intensivist input will be able to pick this up and guide the nursing team or a junior doctor at the ICU to act immediately. Significant patient morbidity and mortality, because there is a timely intervention. Decrease in length of stay, which will obviously help patients to pay less in the hospital. Then it reduces lots of complications, because you are able to intervene early. Enhance medication safety, because there is no errors. Most of this ICU tele ICUs run on a very well time tested and established SOPs. So as a tele-ICU model work, there is always a command center which has a super specialist doctors who are connected 24/7 to the ICUs via a proprietary platform. So most of these companies have developed their own kind of proprietary platform where people can actually have a holistic view of the patient. Intensivist and help hospitals manage ICU patient, thereby improving the quality of care, increasing the ability of the hospital to manage sicker patients. So they have now better capacity to take slightly critical patient than what they were taking before. Hospitals are able to manage more patients and optimize utilization. Also, since your length of stay is coming down, there is a quick turnaround of all the hospital beds, which is actually a very good sign for most of the hospitals. What is the tele ICU? This is what we already discussed. You have around the clock monitoring of the thing. You get a multidisciplinary team approach. You will have a doctor looking into thing. There will be virtual rounds from a nurse. There will be a virtual round from a pharmacologist. A diet take a virtual round and instruct for the diet and stuff. So there is a lot of advantages which a tele ICU brings to the table for all the remotest place in country. So just a visual photo of how the tele ICU center monitors a patient. Say, for example, we have the tele ICU at Bangalore. You can see there is multiple screen where a resource is able to see different parameters. It may be a radiological observation, real-time charts, or a patient will be viewed physically through a camera, so every signs and symptoms can be observed, and a real-time instruction will be given to the attendant, sorry, to the ICU technician or nurse, where they can attend a patient remotely. So this strategy is now enabled most smaller hospitals in a rural place like Bihar, or a government setup, or a PHC or a CHC in remotest place of Arunachal Pradesh or any other places, to access to a tele ICU platform. So ICU experts anywhere can be then bring the best practice compliances to the table, increase in ICU throughput across the network, optimization of the resources, physician or staff satisfaction is very high. Patients stay local for the care; they need not travel from cities or rural areas, kind of stuff. So let's see how the command center works. So the patient may come into a outpatient emergency or ward in a hospital, then require an ICU admission. A new admission alert is triggered. So once a new admission alert is triggered, there would be a virtual round from an intensivist to monitor or to collect all the data. After that, the admission is virtually done into the ICU. Then there will be an admission review. Intensivists perform medical review at the center. Recommendations and orders are given, what medications they have to be put, what would be a treatment protocol, what are the tests to be carried out, and all those stuff. Then even if basic intervention required, the trained technicians at the hospital end can actually take care of those small procedures and stuff. So all the best can be done. So 24/7 monitoring will happen. And like I discussed, there will be a daily rounds as doctors do or others do a physical round, physical infrastructure. There is always a tele ICU rounds which is done from the command center, where the doctors everything, check every parameter and monitor and write the progress notes digitally for the patient. So in case of emergencies, center is alerted. So two notification and communication ensured. Command centers perform video and data assessment. So immediate review, patient case upgraded priority, immediate assessment of the patient by the command center intensivist happens. Action plan deployed. Command center intensivist order to bedside team. Then constant monitoring will be done till the patient is stabilized. Then standard telemonitoring reassumes when the patient is stable. So in this way, even they are able to handle the emergency cases and stuff. So coming to the last part of the presentation, we can slightly discuss strategies to increase telehealth uptake. One is promote and optimize the use of telehealth service for the safety of the health personnel and patients, while using a framework of healthcare systems providing non-COVID-19 clinical care to determine when in-person is appropriate. Include options for language interpretation as needed. So today, language would be a barrier from most of the cross country or cross state, especially when it comes to a subcontinent like India. So having if we are able to break the language barrier, so any consultant from anywhere in India can treat any patient in the country or anywhere. Communicate with insurer or payer to understand ability of covered telehealth, telemedicine, or nurse advice line services. So slowly policies have been pushed or being pushed so that this telehealth modalities are accepted by insurance companies as a legal way of treatment, and this expenditure is 100% reimbursed. So use teletriage methods for assessing and caring of all the patients to decrease the volume of the person seeking care and facility during the time of highly transmission of COVID-19. Provide outreach to the patient with limited technology and connectivity, and offer flexibility in platform that can be used for video consultation and non-video options whenever it is possible. So let's conclude with a discussion on potential limitation of telehealth. Like every other things which has got pros and cons, there are also concerns in telehealth provision. there is always challenge of availability of real-time data stability, in the sense the internet connectivity in all these places. So how well the internet infrastructure can be up, the telehealth services also can perform so much better. Then situation in which in-person visits are more appropriate due to urgency, underlying health condition, or inability to perform an adequate physical examination. So every time in telehealth, physical examination cannot be done. So few of the particular elements may not be really well suited for a telehealth platform. Need to address sensitive topics, especially if there is a patient discomfort or concern for the privacy, because the decision and stuff, always patients are very scared whether it would go to a third person or it would stay in the digital media or the digital platform forever. Limited access to technology devices, like I discussed, maybe from the rural part where they don't have a technology or access and stuff. Level of comfort with technology for healthcare practice patients. Most of the small towns today may not really have that kind of the senior technicians or senior doctors, healthcare workers may not be that well versed or exposed to the technology, which they need to quickly learn and adapt. Then cultural acceptance of conducting virtual visits is what patients or others have to actually understand. So I'd like to just share a couple of things. That's we are tied up with one of the India's best tele ICU solution, which is known as Cloud Physician. We are their channel partners for northeastern states and any few countries like Nepal, Bhutan, Bangladesh stuff. So anything related to tele ICU service, we will be able to help you out. And also, we have a strategic tie-up with the telemedicine service called Synthagi, where it's mostly a B2B kind of service where doctors can share this app or link to the patients, and they can allow them for a follow-up and all the telemedicine services. Thank you.
Thank you, Dr. Vijay, for your expertise. Now I would like to introduce our next speaker, Dr. Ronit Bora. Dr. Ronit is the co-founder and senior consultant at Integra Ventures. He is a certified consultant for National Board for Quality Promotion. Dr. Ronit holds a postgraduate degree in healthcare and hospital management from the prestigious and India's first business school, Indian Institute of Social Welfare and Business Management, Kolkata, and bachelor's in physiotherapy from Sikkim Manipal University. By profession, Dr. Ronit is a senior healthcare management consultant with experience of working in the field of health insurance, hospital administration and quality control activities. His key area of expertise lies in process improvement activities through quality control, ensuring quality management systems are established and maintained, conduct trainings for healthcare providers, preparing training modules, leading sessions, and effective documentation of training activities.
Thank you, Sangeeta. I appreciate the introduction. It's great to be speaking with you all today. Today, my topic for discussion is the importance of quality in a clinical laboratory setup. So, no matter where a patient has a test to be performed, they should expect the same result. But unfortunately, those who are working in a clinical laboratory will accept that isn't always the case. There's always a chance of error during every phase of testing procedure, be it pre-analytic, analytic, or post-analytic. That's why implementing a quality management system in a clinical laboratory setup is so important. It can help a lab provide patient with the most accurate result every time. Now, if we have to define laboratory quality, then it can be defined as accuracy reliability, and timeliness of the reported test results. And also the laboratory results must be as accurate as possible, and all aspects of the laboratory operation must be reliable, and reporting must be timely in order to be useful in a healthcare setting. When conducting a test, there is always some level of inaccuracy. The challenges is to reduce the level of inaccuracy as much as possible, given a limitation of the testing system. An accuracy level of 99% may at first glance appear acceptable, but the resulting 1% error can become quite large in a system where many events occur, such as laboratory testing. Hence, implementation of QMS becomes necessary to reduce the level of inaccuracy. We all know that health outcome depends on the accuracy of the testing and the reporting of the clinical lab. If any inaccurate results are provided, the consequence can be very significant. For example, unnecessary treatment or treatment complications, failure to provide a proper treatment, delay in correct diagnosis, unnecessary and additional diagnostic testing. These consequences result in increased cost in time, personal effort, and often in poor patient outcomes. Hence, we should try to reduce or minimize the error in a laboratory setup. And now talking about minimizing laboratory error, what we can do to minimize the laboratory error in order to achieve the highest level of accuracy and reliability. It is essential to perform all process and procedures in the laboratory in the best possible way. Since laboratory is a complex system involving many sets of activity and involvement of many people, the complexity of a system which requires that many process and procedure may be performed properly. Therefore, the quality management system model, which looks at an entire system, is very important for achieving a good laboratory performance. Now, talking about quality management system, we can define quality management system as a coordinated activities to direct and control an organization with regard to quality. The definition is used by International Organization for Standardization. In short, we can say ISO, and by the Clinical and Laboratory Standard Institutes, CLSI. Both these groups are internationally recognized laboratory standard organization. In a quality management system, all aspects of the laboratory operations, including the organizational structure, process, and procedure, need to be addressed to assure quality. It is very important to implement quality management system in a clinical laboratory because the complexity of the laboratory process, there are many procedures and processes that are performed in a laboratory, and each of these must be carried out in correct order to assure accuracy and reliability of the testing. An error in any part of the cycle can produce a poor laboratory result, and a method for detecting the error at each phase of testing is needed if quality is to be assured. ISO standards group laboratory process including pre-examination, examination, and post-examination categories. Comparable terms in current laboratory use include like pre-analytic, analytic, and post-analytic test process. The complexity of the laboratory system that many factors must be addressed to assure quality in a laboratory. Some of these factors include like the laboratory environment, quality control procedure, communication, then record keeping, competent and knowledgeable staff, good quality of reagents and equipments. Now, the entire set of operations that occur in testing is called a part of workflow in a clinical laboratory setup. The part of workflow begins with the patients and ends in reporting and result interpretations. The concept of part of workflow is a key to the quality model or quality management system, we can say, and must be considered when developing quality practices. For example, a sample that is damaged or altered as a result of improper collection, or the transport cannot be provided a reliable result. A medical report that is delayed or lost or poorly written can negate all the effort of performing the test well. So proper monitoring and control is required during every phases of workflow in the laboratory. When all of the laboratory procedures and processes are organized into an understandable and workable structure, the opportunity to ensure that all the appropriately managed is increased. The quality model used to organize all of the laboratory activities into 12 quality system essentials, or we can say QSE. These quality system essentials are a set of coordinated activities that serve as a building blocks for quality management. Each of these QSE must be addressed if overall laboratory quality improvement is to be achieved. The quality management system model was developed by CLSI and is fully compatible with ISO standards. Assuring the accuracy and reliability throughout the path of workflow depends on the good management of all quality essentials. In a quality management system, the model of 12 QSE, or we can say quality system essential, must be addressed to assure accurate, reliable, and timely laboratory results, and to have quality throughout the laboratory operations. It is important to note that the 12 QSE may be implemented in order the best suits the laboratory. Approaches to implementation could vary within the local situations. Laboratories which are not implementing a good quality management system are guaranteed that there will be many errors and problems. But the thing is that, if a good quality management system guaranteed, there will be many error and problem occurring and may go undetected. Hence, implementing such a quality system management may not guarantee an error-free laboratory, but it does yield a high quality of laboratory that it detects error and prevents them from reoccurring. So, in a brief, 12 QSE, which we have been talking in a laboratory QMS model, are like the organization. So if we talk about the organization, in order to have a functioning quality management system, the structure and management of the laboratory must be organized so that the quality policy can be established and implemented. There must be strong supporting organizational structure. Management commitment is crucial and must be a mechanism for implementing and monitoring. Next comes the personnel. The most important laboratory resources is a competent and motivated staff. The quality management system addresses many elements of personnel management and oversight and reminds us of the importance of the encouragement and motivation. Then comes the equipment. Many kinds of equipment are used in a laboratory, and each piece of equipment must be functioning properly. Choosing the right equipment, installing it correctly, assuring that the new equipment works properly, and having a system for maintenance are all part of the equipment management program in a quality management system. Then comes the purchasing and inventory. The management of reagents and supplies in a laboratory is often a challenging task. However, proper management of purchasing and inventory can produce cost saving in addition to assuring supplies and reagents are available when needed. The procedures that are a part of management of purchasing and inventory are designed to assure that all reagents and supplies are of good quality and that they are used and stored in a manner that preserve integrity and reliability. Then comes the process control. Process control is comprised of several factors that are important in assuring the quality of laboratory testing processes. These factors include quality control for testing, appropriate management of sample, including collection and handling, and method verification and validation. The elements of process control are very familiar to laboratories. Quality control was one of the first quality practices to be used in a laboratory and continues to play a vital role in assuring accuracy of testing. The next point is number 6 is the information management. The product of the laboratory is information, primarily in the form of test reporting. Information needs to be carefully managed to assure accuracy and confidentiality as well as accessibility of the laboratory staff and to healthcare providers. Information may be managed and conveyed with either paper system or with computers. Both will be discussed. Okay. Next is the documents and records. Many of the 12 quality system essentials overlap each other. A good example is the close relationship between the documents and the records. The information management and the documents needed to be in the laboratory to inform how to do things. The laboratory always have many documents. Record must be meticulously maintained so as to be accurate and accessible. Then comes the occurrence management. An occurrence is an error or event that should not have happened. A system is needed to detect a problem or occurrence, to handle them properly, and to learn them from mistakes and take action so that they do not happen again. Next comes the assessment. The process of assessment is a tool of examining laboratory performance and comparing it to standards or benchmark, or the performance of other laboratories. Assessment may be internal or performed within the laboratory using its own staff, or it may depend on the external agency conducted by a group or any outside agency in the laboratory. Laboratory quality standards are an important part of the assessment process, serving as a benchmarking for the laboratory. Then number 10 is the process improvement. The concept of customer service has often been overlooked in laboratory practices for many years. However, it is important. However, it's very important to note that the laboratory is a service organization. Therefore, it is essential that the clients of the laboratory receive what they need. And a laboratory should understand who the customers are and should assess their needs and use customer feedback for making improvement. And the lastly is the facility and safety. Many factors must be a part of the quality management facility and safety, which includes the security, then the containment, safety, and ergonomics. If we talk about the security, which is the process of preventing unwanted risks and hazards from entering the laboratory space. Containment, which seeks to minimize the risk and prevent hazards from leaving the laboratory and space and causing harm to the community. Safety, which includes policies and procedures to prevent harm to workers, visitors, and the community. And ergonomics, which addresses facility and equipment adoption to allow safe and healthy working condition in the laboratory site. There are one ISO standards that are specific to clinical laboratories, which we can call ISO 15189 or 2:12. That is ISO 15189 and 2012. Medical laboratories particular requirement for quality and competence. Another important international standard organization for laboratory is the Clinical and Laboratory Standard Institute, or CLSI, formerly known as the National Committee for Clinical Laboratory Standards, like NCCLS. CLI uses a consequence process involving many stakeholders for developing standards. Now the key messages which I want to share, since the working mechanism of any laboratory is a complex, hence proper quality control should be taken care during all three phases of the process, like pre-analytic, analytic, and post-analytic. Then the process of implementation of quality systems will vary with the local situations. And next is we can start implementing things which are easily achievable. And slowly we can start implementing the quality process, but the main objective will be to implement all the 12 QSE, that is quality system essential. Let me share with you one frequently asked question. What are the benefits of implementing quality management system in a clinical lab? There are many advantages if we implement quality management system, or if we implement quality in a clinical lab setup. There will be increased confidence in testing report issued by the laboratory. There will be better control of laboratory operations and feedback to laboratories as to whether they have sound quality assurance system and are technically competent personnel. Potential increase in business due to enhanced customer confidence and satisfaction. Saving in terms of time and money due to reduction or elimination of the need for retesting of products.
Thank you, Dr. Ronit Bora, for your expertise. Now I would like to introduce our last speaker of today's webinar, Dr. Ashok Khandelwal. Dr. Ashok Kumar Khandelwal oversees overall operation of hospital. A medical graduate from North Bengal Medical College with postgraduate training in hospital administration from National Institute of Health and Family Welfare, and a trained assessor from National Accreditation Board for Hospital and Healthcare Provider. He carries more than 2 decades experience in hospital industry and 20 years experience as hospital administrator in capacity of medical superintendent and medical director in multi-specialty hospitals. Dr. Khandelwal has had numerous publications, lecture, seminar presentations and experiences in the area of process improvement in a healthcare organization. Dr. Khandelwal has had numerous publications, lecture, seminar presentations and experiences in the areas of process improvement in a healthcare organization.
Hello and very good afternoon everyone. I will discuss for next 30 to 40 minutes why accreditation is the need of hour. It is my great pleasure and privilege to participate in this webinar organized by Integra Venture on a very interesting topic, is COVID pandemic. It is also a great privilege to be with the Bhishma Pitama of quality, Dr. Girdhar Gyani sir. So I hope that it will be very educative and learning program. Thank you, Integra, for giving me this opportunity. So as you know that the subject of discussion is accreditation, the need of hour. Why accreditation is important? To understand this, we first have to identify our present environment in which the healthcare nation is working in our country at the present time. The characteristics of present environment is a volatile because of rapidly changing regulations and the government guidelines. It is uncertain because of unpredictability on the disease course, unpredictability on the human resources requirement, unpredictability on the supplies, unpredictability on the different guidelines of the government also, things which we are using now more cannot use, and unpredictability on the equipment's availability also. The important characteristic of this environment is it is very complex. Why it is complex? Because number one is that by nature the itself is a complex organization, as the persons like doctors, nursing staffs, paramedicals, engineers, administrators, all of them are working in an organization. They have got different goals. The goal, so because when people of and their background is also different. So when the people of different backgrounds and different goals work together, the complexity do develops. And this is the one reason, because of the internal reason it is complex, and external reason is also contributed in present scenario. The external regions are also becoming complex. Earlier, the healthcare was only the domain of nurses and nursing staffs. Now, the people from other areas also, getting involved. They are also contribute, like people from IT, people from administration. So this has made the environment very complex, and the also or of different types. They are not only the customers of out-of-pocket expenditure, but also the customers where their money is paid by their payers, like private insurance, government insurance. Then there are customers who are beneficiaries of different government schemes. So the customer are also very complex. So making a bill, their treatments becoming very complex. And then there are different guidelines of state government, guidelines of governments, guidelines of the associations who are controlling the different specialties. And then the hospital itself, there are different specialties. There are 40 to 50 specialty or super specialty. So because of these things, the organization is very complex. The ecosystem is also very complex. Ambiguity is another important factor because of the volatile nature, because of the uncertainty, unpredictability, because of the complexity, the ambiguity, there is a transparency, lack of transparency is there. You don't know what is going to happen, what will be the cost. You don't know when the patient will be discharged. You don't know, what type of drugs or medicines or treatment protocol this patient will require, because of this rapidly changing scenarios, multiple stakeholder involvement. So besides this, there is a significant external environment, that is the capping on consumables. In recent few months and 1 or 2 years, there is a capping on stents, there is a capping implants. Now they are capping on also the consumables, other consumables also. There is an attempt to cost control. Many state governments controlling, putting the cap on the cost. Even during this COVID era, many state governments and as well as insurance companies have also put the cost. Like cannot provide the treatment in a general ward for more than 8,000 per day, or in ICU for more than 50,000 per day. So that cost control is another important factor. But at the same time, when there is a cost control is there, but the cost is increasing. Expenditure is another problem. In the COVID era, a lot of money is spent on developing the new infrastructure like negative pressure room, developing the separate entry, separate floor for COVID patients, and then consumables which were never used in the history in such a large quantity. Even these consumables are not available earlier in the local market, and even they were available, their costs were very high. So this has resulted in the rising expenditure, revenue. So revenue as a whole, because of now the patients are not visiting hospital. One reason they control the cost by government. Another reason control of the the revenue on the consumables. Another reason. So the revenue also decreasing. Judicial activism is another factor. The very rapidly the judiciary is giving verdict, and even a small error or deficiency invites a big penalty. Error, as you will all know that, or deficiency is all know that in a hospital is not uncommon because of the vulnerable environment. This is the fact. But what we see is that a penalty will go into crores of rupees. Consumer activism is another issue in the environment. The consumers are now very much demanding, and they are not only active on the social medias, but they are also at a time active physically, and the violence and disruption in hospital activities is a common phenomenon. Disruption in the entire process of the healthcare because of the entry of other industries. So, and especially the IT, where used to be a patient and doctor relationship, the patient should be seen a doctor, and when a doctor sees a patient, or when a patient meet with doctor, they say that 50% of the disease is gone. Now you cannot physically see a doctor in the present scenario. But the advantage, this is the disruption which we never thought of 1 decade ago. And even in present scenario, many hospitals and doctors they have not been able to accept this disruption. Globalization is another important issue. Global players have entered in the market, and their competitors are, the small doctor-owned hospitals. They don't have the large manpower technology, nor they have the technology of the IT. They have to, go in competition with the global player. Increasing credit. Now the credit patient will go on increasing. So this will be another to the hospital. And focus on the quality. The quality nowadays is a subject which everybody is talking. And earlier there was no control on quality. Now the government, the NGOs, the customer also, they all are conscious about the quality care. So with this environment, the health sector, which used to be few years ago, and what will be tomorrow, is there is a sea of change. So like in industry, in health care also, there are stakeholders, because the stakeholders, 3 important stakeholders are there: care organizer, care provider, care recipients. Care organizers are the hospital owners or promoters. Now these care organizers can be government, these care organizers can be NGO, these care organizers can be private hospital. Now in the private hospital, it can be, the doctor-owned hospital, it can be tertiary care, secondary care, it can be primary care. The care providers are doctors, nursing staffs, paramedicals, engineers, technicians, managers, and also those who organize the care. Care recipients are the customers. Now these customers are, as I mentioned earlier, that they can be, cash patient, they can be a credit patient, and at some time there are indirect customers like the TPAs, the medical insurance, the government insurance, government scheme like Ayushman Bharat or Bal Vikas Yojana. All these are the recipients, care recipients. Now these different types of stakeholders. Now these different stakeholders have different expectations. So we should know, to run our industry efficiently, the expectation of these stakeholders, the expectation of care organizers. The first and important thing any organization wants: customer delight. They want that any customer who is taking services, he should be a repeat customer whenever he is sick or whenever he needs wellness development. So he should come to the hospital repeatedly. And that is the expectation definitely organizations should have. Increase brand value. In the present era of competition, every organization hope for a brand which a customer sees. Whenever a customer falls sick, whenever a customer wants to take the service of the hospital as in OPD or IPD or other daycare services, whenever they think about this, the hospital name should come immediately to their mind. So that is the expectation of a healthcare organization. As I told you earlier that hospital is a vulnerable organization, is a very complex, is a very providing urgent service. So chance of error or deficiencies are there. So if there is chance of error deficiencies there, that can result into a compensation suit. And as I told you earlier also that the suits can be lakhs or even crores and many crores. Even hospital has to close down. This obviously any healthcare organizer will not, aspire for this. The last, but which is very important, health in a private healthcare being a organization which depends upon the investment, so increase bottom line, increase revenue organization profit, they will also expect that when they are investing, they are doing their business, they will also. So these are the expectation of a care organizers. Let us see what are the expectations of the care providers. The care providers also have their expectation, and if their expectations are fulfilled, then we can expect a quality care. So the most important is the safe environment. Healthcare organization, as I told you, because of the to the failure, to the error, the environment is unsafe. Even for the care provider also, they can develop a lot of hospital acquired conditions. So safety is an important paramount for the healthcare provider also. That is why this year the WHO and International Safety Organization, they have made the theme of this year is the safe healthcare provider. If we have a safe healthcare provider, if their environment is safe, then they can give the care to the patient. So that is very important, and so organizations should make arrangement for safety of the environment. Another is the expectation of is a happy workplace. As I told you that hospital is an environment where there is urgency, where there is where there is unpredictability. So stress will be there in the environment. Now, if the workplace can take some measures, if the organization can reduce all these different types of stress and can train the staff to how to manage this stress, then definitely that organization will do wonder. Increase skill development. Every healthcare providers, they want their growth, their skill development, and that is also good in the interest of the organization, in the interest of the patient, service also. So organization has to provide provision for regular care, regular skill development, regular training of the healthcare provider to all category of the staffs. Increased performance. Obviously, the organization should, make the proper environment, give the proper training, give the proper motivation, so that each and every they perform better day by day. So these are the important expectation of care providers. Now let's come to the expectation of the care recipient. Care recipient are the purpose of any care organization. So without meeting their expectation, the rest of the things are useless. So the important expectation is the high quality care. Every healthcare recipient who enters in the organization, irrespective of the class, paying, non-paying, everyone wants the best possible care. They expect the care should be provided as it should be provided. Another important expectation is the empathy. The care recipient in the present era, they consider that they should be given respect. It is they who are the God. It is not the doctors or nurses who are the God. So they, wants empathy, not sympathy. Empathy can be delivered by listening to them actively, by responsions, by providing them proper information on the cost of the treatment, on the outcome of the treatment, and proper education, how to prevent recurrence of the disease and how to improve their health. Safe care is another expectation. Every healthcare recipient wants that when they seek the care, they, their problems should be solved, they should recover, they should not develop any applications or even complications related to the care they provide. So safety of the cares is very important, as you all aware that whenever a patient enters in the hospital, he have a chance of developing lot of hospital acquired conditions like infections, ulcer, fall from bed, medication error, and many others. So every effort should be made to make their care safe and the patient-centric care. The care recipient always expect that he should be the center of the care. Every should, they concentrate on them. Their care should be provided as per their wish. So these are the important expectation of the stakeholders. Now we have discussed how is the present environment, VUCA, BUCA, which is popularly known as VUCA in the industrial world, and this term was first used by American military to describe the scenario of 21st century. And this word is becoming more appropriate, more apt during this COVID era. Now with this environment and the other stakeholders' expectation, how we can meet expectations when you have got a volatile environment, when you have got an uncertain environment, when you have got a complex environment, when you have got a ambiguous. So how can we meet this clear-cut, expectation of all stakeholders? So my contention is that which is nothing but a structured quality assurance program, is the solution. In our country, majority of the hospitals are run in an informal manner, and almost more than 80% of the hospital are less than 30 beds, and more than 90% of the hospitals are having staffs less than 10. So with this scenario, a structured quality assurance program can ensure the meeting of all stakeholders' expectation. Not only the expectation also, but there has been a big market driver like medical value travel, the medical tourism, people coming from different countries for seeking the help, which is a good source of revenue for the medical insurance, NGOs, consumers, judiciary, and government are at different level, pushing, demanding, insisting on accreditation of organization, quality improvement of healthcare organizations. Let us see what is the present scenario from the operational point of view, and what is the requirement in the near future. Present scenario, the healthcare recipients, majority of them are fee for services. More than 60% they spend from their pocket. There is a lack of transparency in the healthcare organization, in healthcare services. What are the facilities available? Who are the doctors? What will be the cost? What will be the outcome? When they will get the investigators? So these things are not readily available to the care recipients. Poor quality is a major issue to all the stakeholders. Poor operational efficiency resulting into rising cost because of lot of waste, lot of deficiencies, lot of errors, lot of optional accreditation. Accreditation is not compulsory except in some government schemes. Unaffordable cost. The cost is the major issue. In recent era, we have seen that a lot of news is coming out in the newspapers, in the TV, in the social medias. Even the governments are also giving the directive. The court also giving a directives on controlling the cost. So unaffordability of the cost is a major issue for Indian healthcare system, and because of this unaffordability of the cost, every year, lot of people in our country becoming poorer and poorer. Ideally, when somebody comes to the hospital, becomes healthy, so he should become richer. But the reverse is occurring, especially in the people, those who are at the bottom. Underutilization of technology. Though we have seen a significant, change in the other industry, be it is a other service industry like the transportation, like the travel, tourism, then e-commerce, and others, we see there is extensive utilization of information technology, but very much underutilized and making it, inaccessible to many area, many, population, many of our country, and to a large chunk of our population. So what we are expecting in the future, in near future is not far away, it may be 1 or 2 years, by 2025, we have to achieve all these things. Government is for the package. The government universal health insurance program, which they are at present, they are targeting percent of the population, that will increase. It will cover almost entire population in the country in next 5 years. And those will not come under this, the private insurance companies. They are also going for the package. They are no more willing to work for the fee-for services. So there will be a big push to the package. The hospital has to work on a fixed rate. Is transparency. Transparency will be the major requirement. Every hospital will be given ID, and every medical record will be online, and anyone can access the care recipient, the care provider, those who are paying, anyone can access what type of care is being provided, how much cost is being incurred. So there will be huge change, quality care. Every hospital has to something to improve their quality at their level. Be it is a 10-bedded hospital, or it is a 30-bedded, or 50-bedded, or 300, or 500. Every hospital has to improve their quality. And that improvement has to be continuous. And this quality is done by the regulatory agency, by the payers, and that is possible through their medical records. So that is the big boost the health industry will get. Increase operational efficiency. Health suffering from operational insufficiency. Operational efficiency has to be improved to survive in the market, because the cost, we have to control, we have to provide the care at a cost. So we cannot spend money here and there. It has to be value-based care. Every naya paisa that is being spent must bring some value to the care, some value to the person who is paying the money. So that operational efficiency has to be achieved. Compulsory accreditation. Hospitals will have to go for accreditation. Now, without that, they will not get the patients. Affordable cost. Cost has to be affordable. Government is going to make the, capping, ceiling, fixing the prices, which is affordable to the customers. So all efforts has made to make the care affordable. So all stakeholders has to learn the skill to reduce necessary waste in all forms, be it in the material, be it in the process, be it in the equipment, be it in the investigations, be it in the other supplies. So cost consciousness has to be developed. Higher utilization of technology will be the main thrust. For bigger hospital, they will be utilizing artificial intelligence. For the smaller hospitals, even they can have a cloud system. They can have utilize HIMS, MRT. So depending upon the level at which we are providing the care, we have to utilize all sorts of technology available at our disposal to survive in the market, to keep our health of the hospital healthy. So economic advantage of this of accreditation is that it will increase the operations, it will increase the quality care, and reducing hospital acquired conditions. But in the cost, it will make the affordable cost to the treatment. So this is the economic advantage. Let's see a few examples of this economic advantage. If we implement the accreditation, there will be increase in 20% revenue from new customers. A reduction in the hospital acquired infection can reduce 30 to 40% reduction in the total cost. Increase of operational efficiency can also increase 30% revenue in the hospital. How accreditation? Most commonly, accreditation being practiced in our country is the NABH for the hospital, NABL for the laboratory. I will share my experience with the NABH accreditation process, that how AI environment can be managed with the two important chapters of accreditation called responsibility of management and human resource. A management will set the vision, mission, goal, will select the right persons, knowledge, and proper training in the disaster management, training in the day-to-day activities, training in managing the risk. We can, efficiently manage the volatile environment and can navigate in this turbulent world. Uncertainty of the healthcare organization, facility management system and all infection control chapter can help a hospital or manager or administrator to make its environment of the patient, the process which are risky. So to make the hospital more reliable by implementation and integration of all the objective elements of these chapters. Complexity of the environment can be managed with the proper communications. So PRE, patient rights and education, is an important issue. And then their performance, measuring the performance of other staffs, measuring the high risk one, measuring the quality, we can make the more simple with the help of quality tools. So the chapter PRE and the patient safety and quality can help us to really face the situation generated by this VUCA environment. Ambiguous environment can be made transparent by the chapter implementation, AAC, no access, assessment and care of COP, care of patients, management of medications, and information management systems. So all these things, the customer or all stakeholders can know that what they are providing, how they are providing, where they are providing, what is the possible outcome, what information we have to provide to the customer, what information should be provided to doctors, and how to record them, and how to make them available to continue to the care, and even for the audit and evaluation. And also that can be made accessible through them and the medical record, all the stakeholders at any time, at any place. So this is how the accreditation can help us, can help an organization, be it small or is it large, to cope up with the environment, this turbulent environment of 21st century and in the COVID and the post-COVID era. So every healthcare organization and its top management should consider the implementation of accreditation. I would like to share some problems that they may encounter while implementing this, and then I will share, tell you, communicate with you how to manage these problems. Problem are the lack of top management, commitment. Top management commitment is very important. When they down the, all categories, they know that the top management is committed for quality assurance program, for accreditation. All of them will do their best. Lack of qualified and trained staff. So hospital must recruit some qualified staff, appropriate qualified staff, and can train the other staffs in the animation standards, in the safety standards, in the standards. Poor infrastructure due to the lack of knowledge and the many hospitals infrastructure is not appropriate, so that has to be developed, and sometimes it is also required for appropriate infrastructure, because the quality depends upon structure, process and outcome. So the structure has to be there, appropriate structure for manpower and appropriate structure for in the form of building, in the form of space, in the form of equipments, in the form of materials. That is very important. Indifferent attitude of clinician. Clinician has been found to be indifferent most of the time at many hospitals, indifferent to the quality process. They should be engaged. They should be involved. The organization must emphasize, must provide them information that the scenario has changed. So if they are not on the board for accreditation, they also suffer, because there will be less customer, there will be less payment. As you know that accredited hospital, they get 10 to 15% payment more than not accredited hospital. So obviously this information will be of great motivation to them. And also the fear of compensation, fear of the violence will also help them to engage themselves. And not only this engagement will help in preventing all these things, but also they will enjoy working more, because if the staffs are, if the process is smooth, and then the outcome of the patient will be better, and obviously a clinician this most, and that will ultimately increase their performance also. Lack of change leaders. Now most of the time we see that in any organization, people don't want to change. Don't want to change because of the fear of change, because they may think that they may not be able to manage this, because of they may lose the job, self-esteem, lack of self-esteem. So you require some lack of change leaders who are able to initiate the change. They require different strategy. So hospital must identify the person in the organization who are able to provide leadership in changing the environment. Lack of engagement of employees. Employees are less engaged with the activities, with the organizational improvement. So if they are less engaged, then we will not be able to accreditation. Lack of budget allocation. And obviously you also must have a budget, but it does not mean that if we spend money on quality, that will go in drain. No. If you spend 1 rupees, you will earn 100 rupees. That is the result of the quality. But only you have to understand how we are, earning, how our revenue is being increased. That you have to understand. If you can understand that, then budget will not be a problem. Rising cost of technology. Technology cost is also increasing. So that is another barrier. So there we have to also put some budget. Lack of collaboration, communication, and cooperation. This process is very important. All stakeholders, employees across the organization, they must communicate at each level. The communication from top to bottom, from bottom to top, lateral, diagonal, in all directions communication should be established. Collaboration should be encouraged. Conflict should be minimized. Cooperation should be sought, should be encouraged, should be awarded, rewarded, so that the all employees they work like a team member. The strategy to overcome, how we will overcome this. So first of all, first step is the preparation for change. So you must decide that we are going, we want to survive in the 21st century. So we are going to change. Then define the change. What are the change required as per your organization? Is it 30-bedded or 50-bedded or multi-specialty, going for entry level or going for full accreditation? So, and depending upon, you have to define the change what you require in structure, process, in the outcome. Identify the change leaders, as I mentioned, is very, very important. Transitioning phase. So once you prepare yourself the change, you define the change, you define the leaders, then you will have a communication established, and gradually a time will come. People will in a mood to accept this. So that's the transitional phase, and then comes the communication phase, when you will communicate to all the stakeholders and will control the resistance. So any resistance is coming from any stakeholders, you have to explain them, you have to help them out how to overcome their problem they are facing. So if you listen to them, if you provide them appropriate training, appropriate counseling, then we will be able to manage the resistance. And once resistance is gone, now you are ready for planning and implementation, and then you can plan according to your organization, the standards you are planning, then the days you are having in your hand, the manpower you are at your disposal, and then you implement. You can use the different quality tools for planning, for implementation. Then training is very important, training of all the staff in different process and policies, and then providing mentorship coaching. Every area should have one senior person working as a champion, working as a motivator, working as a guide, so that he will, train the people in that area. He will provide the mentorship in that area, so that any obstruction, any problem they face, he will provide the support. And finally, you integrate the entire standards or quality assurance program with the entire organizations, be it is a front or a back or top or a bottom, all across the organizations. Even you can involve the patients and the family member in this program. So accreditation is a need of hour because of the changing scenario. So health mission who wants to survive, they have to go for accreditation. Thank you.
Thank you, Dr. Ashok Khandelwal, for your expertise. Now we will start with our question and answer sessions.
So we have a query from Mr. Arun Barua.
Yes, yes. Yes, definitely. NQuas also help any quality assurance program. If price and implements, NQuas will also help definitely. I think that I have given an answer.
Yes.
That yes, definitely NQuas will also help. And the recent guidelines by IRDA released 2 days back, they have also included NQuas as an alternative for
NABH for hospital.
Okay, so before talking about this, Mr. Arun Barwa had a question about ECAS, right? So I'd like to answer that question first. So is it audible? Hi, Sangeeta.
Yes, sir.
Am I audible?
Yes, sir, you are.
Ha ha ha. Yeah. So ECAS is basically external quality assurance scheme where a lot of it's an external thing. So for quality assurance, you need to do two things. Like one is external and another is internal. So for external, there are two things that you can do. One is ECAS and other is ILC. So as you are asking about ECAS, ECAS is basically the external quality assurance system. Here, what is done is, for example, in biochemistry or hematology, there are a lot of labs who participate for ECAS, and there is one organizing company or institute. They will send samples or hundreds of laboratories. All of them, they will run the samples according to whatever test scope they have enrolled for. They will all put their results. So all these results will be compiled by the organizing company. They will put all the results and they will put that all their results in a form of a normal curve, and they will give you the Z value. So among all these laboratories, where do you lie? So basically that is ECAS for biochemistry and hematology. For other ECAS like for microbiology or for serology or for histo, cyto, the kind of ECAS that is different. So they'll give you questions. So all those questions you will have to answer. So that organization, they will send samples. Okay, so they will send samples, and you have to run that. I mean, not run, but analyze it, and then whatever result you get, you have to answer the questions. So according to questions, you'll be given the marks, and that way the ECAS is basically done. If you have a particular or a specific question for ECAS, then I can still answer. Mr. Abhijit, Mr. or Mr. Barwa, Arun Barwa. Okay, if you cannot contact, you can just type in. So this slide, I'll just move into this slide. So basically, we have done NABL. Thank you. Okay, I got a message from Sir Arun Barwa. Okay, so this slide here we have just mentioned the process that we undergo when we are doing NABL accreditation, basically which follows ISO 15189/2012. So here, what we first do is we do a gap assessment first. We have the standards with us, so we see where the laboratory is. So where they are currently at the gap assessment, we plan out that these things should be done. Okay, then we simultaneously, right after that, we simultaneously work on the manuals and SOP. The manuals and SOP can be different for different labs, because every lab has can have a different equipment, and those different equipment can have different ways of conducting those analyzing the the parameters will have different different ways of analyzing it. So the SOP will be different for all laboratories, and there are a lot of specific things that still needs to be done according to the laboratory and the equipment chosen. Okay, and simultaneously we also implement forms and formats which is required in various departments like store, sample collection, your equipment department, and the laboratory itself, and the whatever department they are going NABL for, like biochemistry, hematology, clinical path, etc. And then we also do training. We also conduct training for the staff, and basically to implement the ISO 15189 standards. Okay, and then whatever organizational things that we need to do, like getting the certificates, various certificates and all. So we guide them, guide the laboratory to get those certificates. And then after all the process and running samples, internal quality assurance, everything is done, we will have data set with us, and with that we apply. First, we before applying, we is basically we are doing an internal audit, internal audit. Okay, okay. So internal audit we are doing it, and once the audit is done, we are again finding NCs with that, and we will be working on the NCs. So once the internal audit is done, we facilitate the management of the lab and everybody. We conduct a meeting and we discuss about the NCs. We discuss about a lot of things going on in the laboratory, and the specific things that we are supposed to discuss is, once that is done, we apply for an will. After applying, we can go for pre-assessment if there are a lot of things in our scope. And after the pre-assessment is done, they may raise some certain NCs, and after closing those NCs, we get a final date for. Then we prepare for the final assessment. We get a date, and in the final assessment, there will be. For each department, there will be one assessor, there will be a lead assessor, and they will be there in the laboratory in the department for 2.5 to 3 days. Okay, where they will see everything about the whole process of how you are running the samples and all the documentation that we have done in all that month's time in the preparation. Okay, and after that they may have some and still have some NCs which will be raised, and after closing those NCs, and then we will get the NABL accreditation. Okay, and after 1 year we do a desktop assessment, and after 2 years they will again come for reassessment. But at the current scenario, due to COVID, NABL they are focusing mostly on getting NABL under molecular biology. So in molecular biology, the kind of work that we have to do is very specific, and it is possible to get NABL accreditation in molecular biology within. It depends upon basically the preparation and whatever documentation and equipment that the lab has. If everything is there, the lab can go for apply for the accreditation within 2 to 3 weeks. Okay, so we can say within 1 month we will be able to complete the whole NABL process for molecular biology. And after doing that, using the certificate that you get a permission from ICMR that you can do COVID samples. Okay, and till now we have done more than 80 hospitals and labs, helping them in getting NABH and NABL accreditation. Currently, the total number is about 14. So out of which 3 labs, 1 lab has already got the NABL accreditation, and in molecular, and I'm talking about molecular, the 14 ones. So 1 has already got, 2 have completed with their assessment. 3 labs will be doing their assessment this next week. Okay, so
thank you all for attending today's webinar on strategizing an efficient healthcare delivery system. If you have any queries, then you can contact us on the given details. Thank you Dr. Girdhar Gyani, Dr. Ashok Khandelwal, Dr. Jyoti Das Dr. Vijay P.V. and Dr. Ronit Bora for your expertise, and thank you everyone for joining us today, and we will see you next time.